Shield Connect. I am Nishan Chawda, Regional Medical Advisor from Shield Healthcare. It's my privilege to welcome you for this wonderful series, Trending Us series, which is organized by AGOG, Academia of Global Obstetrics and Gynecology on Shield Connect platform. So in this task series, we will be covering the topic from A to Z topics, and the today's episode is which will be covering the topic infertility insights. So before we start with the series, let me show the short introductory video for AGOG. And so with this, let me start the episode with small Vandana prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
And I am now happy to introduce the coordinators for this episode. Dr. Ritu Hinduja and Dr. Kalyani Shrimali. Dr. Ritu Hinduja is a consultant fertility specialist at Nova IVF, Andheri, Mumbai. And I also welcome Dr. Kalyani Shrimali, ma'am, who is a senior gynecologist and fertility consultant at Nova IVF Fertility, Indore. So I am happy to hand over this session to Dr. Ritu Hinduja, ma'am. Thank you, ma'am.
Thank you for the introduction. I will now request Komal ma'am to introduce our guest of honor and our chief guest and take this program forward.
Thank you, Ritu. Thank you so much. And at the outset, I welcome you all for this Trending Ask the Expert series. And we are here with the episode I. And I for infertility. And Infertility Insight is the episode today. And we have all our luminaries here who have joined to discuss the most trending topics in infertility. And without ado, I would welcome our chief guest for today, Dr. Nandita Palshetkar. And I think everybody knows Dr. Nandita Palshetkar. She's so well known in the field of infertility. She's one of the pioneers and has done immense work, and being the president of ISAR for the current year. And she has bestowed the fellowship honorary causes from the Royal College of Obstetrics and Gynecology, eminent IVF specialist with 28 years of experience and heading so many chains of Bloom IVF all over India. She has also been the past president of FOXY, IAG, MOGS, and she is a diva icon. Like, we all look up to her at various aspects, may it the way she carries herself or way about her, everything. You are overall a person and a trendsetter for all of the leading gynecologists here. So I think, you have received so many awards. If I go into the detail, it will really take a very long time, but the awards are so exemplary and they are all from the national and international field. So thank you so much, and also received the B.N. Purandare Outstanding Award, and also received the Femina Women Super Achiever Award. So these are the few awards which I can name. So over to you, Dr. Nandita, madam. Please address our audience.
Thank you, Komal. Thank you for those lovely words. First of all, congratulations, Komal and Niranjan, for this A to Z series on infertility. I think it's wonderful. In fact, when we had the managing committee meeting in Delhi, it was actually told to us by Dr. Bhaskar Pal that the most attended workshop was the infertility workshop with nearly 1,700 plus delegates. So I think we need to understand the importance of infertility in general OBGYN practice. And today's episode, which is focusing on infertility and having fabulous speakers. I think I can see my friend Narendra over here. I know him for 30 years, and he's talking on a lovely topic of how to increase success rates in IUI. I think IUI is something that is so important and so basic, but one of the most, difficult to achieve success in, unless you do it perfectly. And who else better than Narendra to tell us about it? And another person who's really experienced, Asha Rao, talking about adenomyosis, another good friend for so many years. And then the panel discussion on repeated IVF failures. I think, IVF since its inception in 1978 has really become very popular. And today people go for it very without hesitation. So we are seeing a lot of patients with repeated failures. And I think it's one of the burning questions. What do you do in repeated IVF failures? There is so much to do in pre-IVF and with the laboratory advances and post embryo transfer. So there's a lot to discuss, and I'm sure it will be a wonderful webinar and lots to learn. So I won't talk too much, but leave it to all the experts over here to deliver their knowledge, and so that all those tuning in can listen to them and give the benefits, translate the benefits to the patient. So thank you, Komal, for inviting me here, and it's good to see Ritu and Kalyani over here conducting it, and of course, I'm very happy that Fessy Louis is here with me, another person who I've seen, grow by leaps and bounds in Foxy as well as ESAR. And I'm sure it will be a great event. I don't know whether Sonia has come in and Prerna, but I can see all familiar faces. And I think that is the beauty of Foxy, that we all develop. It's like a family, and it's really wonderful to see everybody here. So Komal, all the best, and I'm sure the webinar will be a great success. Thank you for inviting me here.
Thank you so much, Dr. Nandita. And it was really honored having you as the chief guest. And now I would like to welcome our guest of honor, Dr. Fessy Louis. Dr. Fessy Louis is professor and head of the Department of Reproductive Medicine and Surgery at Institute of Medical Science, Cochin, that is Amrita Institute. And he has been the vice president of Foxy 2021-2022, ISAR National Executive Member, ICOG Governing Council Member, Vice President of Kerala Chapter of IAGE, and Secretary of the Kerala Chapter, and Reproductive Committee Chairperson of KFOG. He has also been the member of...
Komal.
Yes.
We will...
Yes. Good evening, sir. Over to you.
Yes, good evening. I think first of all, let me congratulate Dr. Komal and Dr. Niranjan for this excellent initiative in the Academy of Global of ONG. And this particular episode of Infertility Insights, and I am privileged to be along with Nandita Madam and stalwarts in the infertility like Narendra Malhotra sir, Asha Rao Madam, and a good friend Kundan, and energetic Erika, along with that all other chairpersons and panel members. And let me congratulate the organizing conveners and the coordinators, Ritu and Dr. Kalyani, for selecting these wonderful topics. I think the importance is that all will be doing IUI, but how to optimize success, that is still an enigma among the all infertility practice. And the adenomyosis, which is other thing, whatever we do, we have to be tackling in a very difficult way. That we have got Asha Rao Madam. I happen to see her, hear her personally. It's about the same topic she told about 3 days back at Cochin. And I think Optimizing Success, Malhotra sir is an expert and is a guru in for all of us in infertility. And it will be chaired by Sonia Madam and Dr. Prerna. and also the adenomyosis talk will be chaired by the Dr. Roza and Dr. Sarita, who are very senior in this field. And lastly is the repeated IVF failure. I think all will be doing IVF, but all will be seeing a lot of IVF failures. That is another enigma in this field of infertility. And it will be moderated by the well-experienced infertility chairperson Kundan and young and energetic reproductive medicine MCH holder Dr. Erika Patel. And with all the panel members are experts, we are eagerly waiting to hear from what they will be sharing their experiences, like Dr. Sheetal, Dr. Nisha, Dr. Yuvraj, Brajbala, Dr. Dhaval, Dr. Nousheen from Kerala, and Dr. Shrutika also. So overall, it is the topics are good and the faculty are good. So we are eagerly waiting to hear from all of you. And at the last, we hope that we will be able to take good take-home messages. So we request Dr. Komal and Niranjan to continue this insights episodes into different aspects of infertility and other aspects of the obstetrics and gynecology. With this, I wish all the success for this issue, this episode of the insights of in infertility. Thank you for inviting me.
Thank you so much, Dr. Fessy Louis. It was really wonderful for you to be the guest of honor today. And I would like to say that Dr. Narendra Malhotra, we started this series with episode A, and Dr. Narendra Malhotra was there to bless us at the first episode, and I'm so happy that he is a faculty today to deliver a talk. And we are all, and the banner and the backdrop, the energy which he has put into this talk is so amazing. So I think we should not come between the academics, and really now all the chairpersons, everybody are all senior. Dr. Sonia Madam, Dr. Roza Madam, Dr. Prerna Shinde, Dr. Sarita, they all have joined. So let's begin with our academics. Over to you, Ritu, and welcome both the speakers, Dr. Narendra Malhotra and Dr. Asha Rao.
Thank you, ma'am. Thank you, Nandita ma'am and Fessy Louis for blessing our program. And we are so grateful that you could log in. Moving on to session 1, which is Optimizing Successes in IUI. Our chairpersons are Dr. Sonia Mallik and Dr. Prerna Shinde. However, these two people do not need any introduction, but I'll make a little attempt to introduce them. Dr. Sonia Mallik is the director and HOD of South End Fertility and IVF2 and Nova IVF along with South End Fertility. She is a dynamic person, so warm, always there to help us out, whether it's academics or anything else. Thank you, ma'am, for always being there, and we welcome you for this program. Our second chairperson is Dr. Prerna, who is always smiling, always approachable, and such a friendly person. She's been practicing OBGYN for the past 28 years, and she's our chairperson today. So I welcome both of you all for this session today, and I request you to please introduce Dr. Narendra Malhotra sir for our talk.
We can't hear you.
Ritu ma'am, you're on mute.
You're on mute, yeah.
Okay, Sonia ma'am is here. So ma'am, you can introduce Narendra sir.
You know what? Actually, I was listening to what you were talking about us. And here we have a speaker whom nobody needs to know more about. I mean, I think he's the most omnipresent person in the field, in the world of Foxy and beyond. So it would be, you know, like showing the moon to everybody by saying that here is the sun, and do we need more for sunshine? No. I think he is an enigma himself, and we shouldn't waste time introducing Dr. Narendra Malhotra. Everybody knows him. We are very eager to listen to what you have to tell us today. Let's not waste time and start with it.
Yes, yes.
So mute. Narendra sir.
Narendra, you're muted. Yeah.
Yeah. So
It's indeed a great pleasure to be here with all of you today to speak on something on how to increase the success or optimize pregnancy rate. And this is always going to be an enigma. And whatever we do, we still with IUI, what people claim that every IUI do, people get pregnant. It is not like that. So we need to understand that IUI has its own limitation. So before we go on to IUI, let's understand what infertility is. It is defined, we all know that. It's a clinical social problem affecting 1 in 6 couple now, 13 to 15%. It has got like a jigsaw puzzle, both male, female, unexplained, and both factors together. And we have to put this jigsaw together to understand and get the best results. IUI is the most common procedure performed by every gynecologist in their infertility practice. Remember, whoever is listening to this, there is a new ART law, the new ART bill of 2023, and it mandates all centers who are going to do IUI to be licensed and registered. So please, if you are doing IUI and you're not registered with your board, state board, please get registered. Otherwise, it becomes an illegal. And when it becomes illegal, there is a very harsh punishment for it. So do get yourself registered. The IVF registration is separate. So it's a very simple, safe, less invasive, cost-effective, efficacious modality. And it's very easy to establish an IUI center. So what is IUI? It is to increase the rate of conception and couple by increasing the chance of maximum number of healthy spermatozoa reaching the site of fertilization. So we're going to put in washed sperms as near as possible intrauterine to the ostia cornua so that they have a lesser distance to flow. The success of IUI, if you review the literature over the last 15 years, shows a wide variation. Some studies have shown 0, and some studies have gone up to 26%, and that's the maximum which studies have shown world over. So, and there is a cycle for different indication because the percentage will depend on indication. The take-home baby rate is controversial, and there's no evidence-based infertility data on the take-home baby rate. When we compare timed intercourse with IUI, ovulation induction with clomiphene, IUI you get 6.3%, with timed intercourse you get 2.3. So it almost about doubles the rate of the success with timed intercourse if everything is normal. And when you're going to stimulate with gonadotrophins, the success goes up to 14.8 as compared to the timed intercourse of 6.7%. So let's talk on the 10 tips for enhancing IUI success. And these are my 10 mantras or 10 tips for all those who are going to do IUI. And of course, we'll come to some conclusion and take home messages also. So the first is your lab and equipment. Second is your selection and workup of patients. Third is your ovulation induction protocols. Fourth is how you monitor the stimulated cycle. Fifth is how you time the ovulation trigger. Sixth is the timing of the insemination. Seventh is the lab standard and the semen washing technique which you're using. And then eighth is the IUI procedure or technique which you're using. And then of course the luteal phase support which you're going to give. And finally, when to stop and refer for ART, which is the most important thing which you need to understand. So let's go one by one, and as briefly I'll try to take you through them. So the lab environment and the lab consumables and the contamination-free lab and the correct and good quality equipment. So good quality control, standardized equipment, good air quality, standardized culture media, sterile toxicity tested disposables, avoid major chemicals nearby and clean the lab, proper collection, liquefaction and processing of the sample. No sample collection in the bathrooms, please. That contaminates the thing. The instruments which are required for a basic semenology lab and an IUI lab, the list can be attained everywhere, but quickly you need a sperm counting chamber, a centrifuge, a microscope, an incubator, which could be CO2, could be non-CO2 also for temperature, some liquid nitrogen for sperm storages, cylinders, laminar workflow, computers, test tube racks, slide warmers, fire heights, refrigerators, micro pipettes, pipette controllers, cabinets, spirit burners, and disposables. So these should be there in your lab. You cannot say that I'm keeping my test tube on the table or here and there. That should be proper. So the tip number 2 or your point number 2 is proper selection of the patient and the indication. And that is the selection of the female, the male, and what indication are you going to do. So for the female, the age, the duration of infertility, the cause of infertility, the semen parameters, number of previous IUI cycles, very important. So IUI is recommended whenever there is evidence of insufficient sperm reaching the upper genital tract of the female partner. So low sperm count, vaginal infections, cervical problems, and things like that. So we need to evaluate both the male and the female and the couple together with a proper history, proper physical examination, test the semen, do the sperm function test if required, if it is poor, do a proper ultrasound evaluation of the female and the male if it is oligospermia and all, do an endocrinological study where needed, and if needed, a laparoscopy or a hysteroscopy. Most of the problems we are now going to diagnose by TVS with contrast, and if you have 3D, it is much better. So you don't need a laparoscopy for everyone, because laparoscopy will pick up only peritoneal factors which ultrasound does not pick up. Rest, fibroids, endometrioma, PCOS, tubal patency, all can be done by ultrasound. So we do ultrasound more. Then the proper indication case to be selected for proper indication. For sperm deposition disorders, ejaculatory function impotency, hypospadias, vaginismus, oligoastenospermia, hypo volume, retrograde ejaculation, cervical factors, absent cervical mucus, hostile cervical mucus, mild to moderate endometriosis, unexplained infertility, immunological infertility, and combined factors. AI with all donor sperms, then storage of husband semen prior to his surgeries and all. That is where we'll need a storage and a cryofrozen samples before vasectomy, sperm toxic drugs, all that. Absentee husband, fear of failure to produce sample on demand, so sample is frozen before it, and poor semen parameters. Now, when we look at this article, which is in 2008, when you give clomiphene citrate with IUI, you see the success rates in various groups. So the age is very, very important. You see, the minute the patient goes over 37 in the Western countries, in India, it is 5 years lesser, because Indian menopause comes 5 years lesser. So our ovarian reserve in Indian is lesser. So as soon as an Indian woman is over 35, your IUI success will be only 3 to 6%. And at 40 crossing, it will be 0. So doing IUIs on 40 plus is, you might get an occasional pregnancy, 1 in 1,000 or so. But please don't waste patients' time. And also same with the maternal age. Fewer oocytes, lower E2, lower implantation rate, increased risk of miscarriages, and increased chance of chromosomal anomalies. So that we have to keep in mind. Then the second thing with these couples, we have to keep in mind the duration of fertility. So if they're less than 5 years infertile with IUI, they're likely to conceive 14%. If it is more than 5 years, the conception chances 6%. So again, this has to be kept in mind. So early referral or early proper treatment and not waste their time is the mantra for all of us. Then the etiology. If it is male factor, if it is unexplained infertility, you get 15%. So mild male factor, you get about 11% success. Ovarian dysfunction, you get about 10% success. Endometriosis, mild, 6 to 7%. And after operation of endometriosis, again about 10%. So that is how we have to keep in mind, because this is very important to counsel the patient and for your this thing. Then the semen parameters, whether you're going to do IVF, IUI, or ICSI on the first examination. So if your initial total sperm count is more than 10 million per ml, initial sperm mortality is more than 30%, post-wash sample is more than 1 million per ml, 24-hour survival of processed sperm is more than 70%, TZI is 1.85, HOS is less than 60, IUI would be successful. But if it is less, then you have to select whether you're going to do IVF or ICSI. So the semen parameters for IUI, less than 2 million, 2 to 4, 4 to 7, more than 7. And you see, if it is less than 2 million, the pregnancy rate is 0. So this patient has to go for ICSI, not even IVF. Maybe IVF can be tried. But if it is more than 7 million semen parameter, then 17% success is likely. Then you have to watch for progressive motility PR, and you have to watch for the total motile sperm count. This needs to be done before you are selecting your patient for IUI. And then morphology. Strict morphology criteria of 4%, insemination motile count more than 1 million, total motile sperm count more than 5 million, total motility in native sample more than 30%, IUI you can do. So that is to be. So a lot of this literature has compared all these, and this all of you can go ahead, go and read all these papers and decide on. But broadly, I'm telling you. So then, of course, the sperm DNA and the predictive value of normal sperm morphology with IUI and the sperm DNA fragmentation. Again, the values have been changing with the period of time, and today WHO has labeled it at more than 4% morphology. The sperm staining, horse staining, papnochloe staining, abnormal sperm staining. So if you look at a flow chart, male factor, tubal factor, no tubal factor. No tubal factor, you wash IMC less than 1, IMC less than 1, morphology, IMC more than. IUI 3 to 4 times, does not conceive, go for IVF or ICSI. ICSI, you go straight away if the IMC is less than 1. Tubal factor, washing procedure has to be done. If it is less than 1, ICSI. If it is 1, then may IVF. And if it is more than 1, again IVF, because if the tubal factor is there, tubal block is there, there's no sense of doing any IUIs. So evidence-based recommendation for IUI in daily practice is this. The DNA, sperm DNA fragmentation, if can be assessed, less than 27 and can be done and tested in most of the labs. Our tip number 3 or your mantra number 3 is proper selection of ovarian stimulation. Now you don't have to overstimulate, but you have to stimulate enough to get about 2 to 4 chances. More the oocytes, more better the chances. But that does not mean 20 oocytes and you do an IUI or 10 oocytes. Then those cycles have to be converted. So before we start ovarian stimulation, you have to analyze the ovarian reserve by an AMH and an AFC count. You then define your ovarian stimulation goal. Our goal is IUI, so we want 2 to 4. And then we do a minimal stimulation protocol with clomiphene HMG or with letrozole HMG. There are huge various number of protocols you can use. Clomiphene 50, 100, 150, day 2, day 3 start. Letrozole, tamoxifen, day 2, day 3 start. 2.5 or 5. CC with HCG trigger, CC with HMG with HCG, CC with FSH plus HCG, FSH plus HCG, HMG plus HCG. Step-up protocols, step-down protocols. Use GnRH 0.1 to trigger instead of HCG if you are scared of ovarian hyperstimulation. And low-dose FSH is recommended for PCOS. Now look at these boxes. Anti-estrogens appear to be more cost-effective in it. And by anti-estrogen, we mean letrozole and clomiphene. When you use gonadotropin on daily basis, low-dose protocol, do not differ in success, but high dose will cause OHSS. No role of GnRH agonist in IUI because you'll need their reserve GnRH agonist downregulation reserved only for IVF. No difference in the probability of conception whether one uses urinary or recombinant. Role of GnRH antagonist in mild stimulation protocol needs to be determined, and you can use agonist as trigger or antagonist only to postpone your weekend cycle. So the pregnancy rate will vary, and if, as you can see with gonadotropins, it goes up to 26%, 19 to 26%. And so you can do, if the patient is getting to you at 33, 34, straight away do only HMG or FSH stimulation with IUI and not anti-estrogenics. Our aim is 2 to 4 follicles. Our estradiol levels are not more than 250. Our endometrium should not be more than 9. And IUI is done between cycle day 13, day 16, depending on, we'll come to that. You cancel the cycle if you're getting more than 6 and you're getting a very high estradiol of more than 15, or you convert them early with the antagonist protocol to IVF. So the number of pregnancy you see, if the follicles are 3, the percentage is 16% pregnancy. If it is more than that, the pregnancy rate actually falls. And if it happens, more multiples happen, so more morbidity there. So that is what we are aiming at. We are aiming at 1 to 2 with a pregnancy rate of 13 to 15%. In IUI, one has to remember the control is not in our hands once the eggs are released. So always aim to have the minimum morbidity and mortality. Avoid hyperstimulation. So avoid hyperstimulation and multiple pregnancy rate. That is what our aim is going to be, get best rate. Tip number 4, how are we going to monitor the cycles? So you have ultrasound, you need to do ultrasound. If you get polyps before or in between, cancel the cycle. If you don't get a good ovarian flow, cancel the cycle. If you don't get grade 3, grade 4 power Doppler in the endometrium, cancel the cycle. 2 follicles here with good endometrium is what we are requiring. And ultrasound monitored cycles give you better pregnancy rate than non-ultrasound monitored cycles. 48 compared to 34, even the deliveries are higher. So we need to do Doppler studies for the follicle and for the ovarian and for the endometrial blood flows. And get a good receptive endometrium with a good follicle, and that is what we require. Our tip number 5 is when to time your HCG. So your HCG has to be timed either on the LH surge, or now we do it only on TVS. If it is a stimulated cycle, 18. If it is a non-stimulated cycle, 20. If it is a gonadotrophin stimulated cycle, sometimes at 16 also, depending on how your ovarian endometrial synchrony is, as you can see in this picture. And you can trigger with 5000 HCG, recombinant HCG, or GnRH agonist trigger. So you can trigger it within. Tip number 7 is your timing of insemination. So your timing of insemination should be urinary surge 24 hours if you're following that. Ultrasound follicle monitoring as soon as you detect rupture. Following HCG injection 36 to 48 hours. If you're going to do single, 44 hours. If you're going to do double, 24 hours and 48 hours. So that is broadly the best. So let's expand this a little. Ideally, one should time the insemination nearer to the ovulation. So 36 to 48 hours, if it is a fixed protocol you're following. If you're following the flexible protocol, first IUI at 24 hours. If rupture has occurred, no further IUI. If no rupture has occurred, the second IUI again after the first one in 24 hours or 36 to 40 hours. So single insemination 36 to 40, double insemination 12 to 48. Single versus double, theoretically 2 insemination would be better, but ovulation not synchronized after HCG. So single IUI may miss the release of later cohort of oocytes. Maybe one has released today, one might release tomorrow or day after. So, but when we do a Cochrane review, double IUI shows no significant benefit over a single IUI. So 2 insemination, 24 to 48 hours or single. Now, how much insemination to do? To do conventionally or fallopian tube perfusion? All of us follow conventional method, 0.2 to 0.4 ml. Fallopian tube perfusion is 4 ml. You suspend and slowly inject over the period of 20-30 minutes, I think, or maybe 10 minutes. Slow injection. Tip number 7 is your lab procedure. Oh, sorry, this video is not working. It's showing the sperm preparation techniques. So your lab has to have follow a good sperm preparation technique, and what technique you are going to follow, it depends on the sperm count which the patient had. If the patient had normal or near normal, you do swim up. If the patient had oligo, astheno, or teratozoospermia, you do a density gradient. And there are various, these have been described. All of us are following it. Your embryologist must be well versed with it. Or if you're doing it yourself, to learn how to do these sperm preparation techniques. And the idea is to get a post-wash 1.1 to 5 million per ml count to achieve the maximum pregnancy rate. So post-wash sample has to be seen, minimum 1 and ideally 1 to 5. Apply the right technique depending on what the sample was before at the time of. This is how the swim up is done. Very simple way to do. This is how the spin method is done, and the density gradient and the double spin up. And this is the swim down density gradient method. All these are explained in books, and I need not go into the details of how you do it, but you've got to learn the right way and select the right method. There are some newer gradient available in the market. Please, if it is required, use those. The pre-wash, as you can see on this side, had a lot of debris, pus cells, RBCs, and this one, you got a neat, nice, good sample. Post-wash. Then on the day of IUI, remember, the collection of semen interval to the insemination should be as short as possible. Collection by masturbation, proper abstinence, and both done at the lab or near the lab. You cannot ask the patient to bring a prepared sample from a pathology lab. Someone is coming on a cycle and bring it. That is not right, and you will not get results with that. Tip number 8 or your mantra 8 is the correct IUI procedure. So waiting for 15 to 20 minutes between loading of the syringe and placing the process time in the uterus will result in significant loss of sperm mortality. So as soon as the sample is ready, load it and do IUI immediately. No waiting. If you wait, the mortality goes down and the sperms will, and you will not get a success. Whether you're going to do an ultrasound guided or not, it is again been shown that if you do ultrasound guided, you leave the sperm volume just below the fundus, no touch of the fundus. And that is what the only benefit is. Blindly, you might touch the, scratch the fundus and inject only 0.3 to 0.5 or maximum 0.4 better and slowly withdraw the catheter. Similar pregnancy rates for 0.5 and 3 ml inseminated by fallopian tube prawns. Normal is 0.3, 0.4. TVS, yes, TVS is done. Before that, non-toxic cover, check for ovulation, reconfirm the position, assess the endometrial lining, do the IUI. And there is no significant difference in pregnancy rate if the standard gentle technique with no touch, irrespective of which catheter you use. So you can have to do atraumatic catheter, a little bit, whichever, those 5 catheters which I'm showing you up there, use whichever it is, use the best. Do the patient require rest with legs elevated? No, only 10 minutes of bed rest and then they can go for work. And that has it. If it is a difficult IUI, then acutely stenose, maybe local anesthesia, maybe use the ET catheter and do under ultrasound. What other drugs can you start at the time to use to improve results? Well, some people may start aspirin, vaginal misoprostol to soften the cervix at the time of insemination. And this, some studies have shown, has more pregnancy rates. Our tip number 9 is the proper luteal support. Now, HCG 2000 every 4 days. Giving 5000 HCG weekly is not the right protocol. 2000 every 4 days because of the half-life, not weekly. Even in pregnancy support, we should give it every 4 days. Progesterones, daily progesterone, micronized progesterone, depo-progesterones, gels, vaginal tablets, sustained release tablets, dydrogesterone, all that, any progesterone is going to work the best. Micronized gel probably work better, but today dydrogesterone studies are showing that the results could be equally same. So whichever you're comfortable with, but use only one progesterone. Now, a lot of people give 3 progesterones, 1 injection weekly, 1 vaginal tablet and 1 dydrogesterone. That is not right. That is not scientific. That is not evidence-based. Our last tip is, when do we stop? That is the most important tip. When do we stop? 1, 2, 3, 4, 5, 6. So in the first 2 cycles, you're going to get 71% pregnancy. In the first 4, about 80%, and then the pregnancy rate will fall. So ideally 3 cycles or maximum 4, and then you rethink, reevaluate, and probably take her up for laparoscopy to rule out the peritoneal factors. So if it has not been done before, or shift them to ART earlier or better. Some other considerations in addition to these 10 tips, there are some myths, and be careful. There's no reason to believe that IUI is more successful than natural, only slightly. Pooling of sample is a myth, not beneficial, because you pool it, you'll freeze it, there you lose it. Pre-treatment motility enhancement agents improves results, doubtful. Longer and faster centrifugal reveals better, no. Epididymal sperm aspirate can be used, never. Simple feeding tube yields same result, no. Proper IUI cannula. Number of IUI increases pregnancy rate, absolutely no. 3 to 4 is there. There are some contraindications which all of us should know. Tubal pathology, infections, severe sperm abnormality, don't try IUI, shift her to IVF or ICSI better. Genetic abnormalities in the husband, pelvic masses, older age group, extensive pelvic surgeries have happened. Pregnancy is contraindicated to that patient, and chemo and radiotherapy. What about frozen samples? For cryo-frozen samples should be used always for donor insemination. What about retrograde ejaculation? Yes, you can do. Alkalinize the patient first, collect it in bicarbonate, collect it in a buffer, and then immediately prepare it. And then anti-sperm antibodies, if you're examining the sperm on the first day, you see agglutination head to head or tail to tail, then again you have to do collection in a buffer and immediately prepare them. Pooling of the samples is not a good idea. So the good prognosis would be age less than 35, 4 follicles, good plasma estradiol, not more than 250, 4 million motile sperms per insemination, slow release, good endometrium, good luteal support, and very, very important is tender, loving care. And not say, "Ayo, yoga, chal bhag." Not like that. Tell the family also to support it. So my active management of infertility is that if you should do a single cycle evaluation, not waste patient time by calling her repeatedly every month. This month we'll do endocrine, this month, next month we'll do ovulation, next month we'll do laparoscopy. Do not deplete the fixed ovarian reserve by repeated clomiphene or letrozole, and refer her early. So the active management in young patients with less than 5 years, I call them on day 2, do a semen myself, scan them myself to rule out fibroids, endometriomas, polycystic. If needed, do a hormone assay. If everything is all right, start a letrozole or clomiphene trial. Day 7, I call them again for a sonosalpingography with normal saline and some antibiotic, and start the follicle monitoring. When the follicle is 18, give them a trigger, and depending on what the condition is, timed intercourse or IUI, and we can call them after the timed intercourse and do a postcoital test, though it is not required. Only if the husband is not willing to get a semen analysis, we can do that. Again, P4 levels are not required to tell you whether the secretory or the corpus luteum defect is there or not, and that can be seen by sigma. So IUI 3 cycles, shift. If the patient is 35 to 40, only 3 cycles of IUI, shift them to IVF. If the patient is over 40, no IUI, no laparoscopy, please. Unless there is a fibroid endometrioma or a disease. No diagnostic laparoscopy, I mean. And counsel them straight away for medical fitness, genetic diseases, and counsel them for oocyte donation if the AMH is very, very low. If the AMH is low also, about say 0.8 to 1, we can still do pooling of oocytes. Counsel for PGD, start counseling for adoption and surrogacy also. So ladies and gentlemen, it's an experience which makes the clinician expert, and you all are already good expert clinicians. If not expert, let your experience make you an expert. Thank you very much for inviting me here to tell you something about IUI, whatever I know.
Yes. Thank you, Dr. Malhotra, for such a precise and informative and very detailed information regarding IUI. I think I'm very sure, like, since so many years, everyone has been doing IUI. Maybe I'm doing since last 25 years, but from your lecture, there are always many take-home messages. One thing I would like to ask, you just mentioned that there's an important point and that every clinician faces this situation. When to give trigger? You just now you have mentioned that you give trigger when the follicle becomes 18 millimeter in size. So you go with the according to size of the follicle or the color Doppler, like when you see the ovarian flow is 1/3 of the ovary, 1/3 of the follicle that time. So which point you give more importance, ovarian this follicular flow or the size?
So the follicular flows tells us the quality of the oocyte inside.
Perfect.
And we don't use it for triggering. If you have a good follicular flow with the follicle at 16 or 18, you're sure that there is an M2 oocyte inside it. So triggering still we go for with the size. And very soon, I think we'll start going by volume when all of us start using volume. And I would definitely do before triggering a color Doppler follicular flow. If by chance the follicular flow in the endometrium is poor and the oocyte also not showing good follicle, I may wait for one more day. But that is it. Otherwise, it is going to rupture itself. Now, color flow is a delicate. And your machine sensitivity depends on machine sensitivity, the operator. You might not get a color flow and I might be able to demonstrate the color flow with the same machine. So you have to be a little bit of an expert on a learning phase to demonstrate slow color flows with the correct power Doppler settings. So that is all important. So that is why we don't go by color flow right now, but go by size more.
I think, Naren, I also add on that endometrial thickness. I would say 7. What is your...
Yes, endometrial thickness is equally important. It has to be minimum 7. If it is less than 7, then there are less. Though pregnancies have been reported at 6 also. But if the follicle is ruptured and the endometrial thickness is 6, you still go ahead and try with IUI. You're not going to waste those follicles.
Thank you.
Can I also join in? Can I make a remark?
Yes.
Madam expert, don't ask questions, you just give comments.
No, I have to ask you. You are the expert. No. Don't you think we should...
मेरे से ज़्यादा experience आपके, मेरे बाल काले हैं अभी.
तूने डाई किया, मैंने नहीं किए. अच्छा, सुन. No, what I'm trying to ask you is, should we revise this?
I don't die natural.
Anyway, I give you that. I grant you that. So basically what I'm trying to say is, should we, given the fact that our menopause age is, ahead and, we are aging faster, why should we restrict? Why should we say that we should be doing IUIs up to 40? Shouldn't we be doing it only up to 35? Because our ovarian reserve is horrible by the time, and if you are going to waste the time of that patient up till 40 years, it's going to be very tough for us. That's what I feel, that, now we need to revise all our thinking and stop doing IUIs maybe even at 35, because we find that the ovarian reserve is becoming very bad. I just want the opinion of all of you over here as experts.
I absolutely agree to this.
Yeah. So
35 is my cutoff for IVF.
Make it cut
35. After 35, they should go for IVF, because Indian menopause is 5 years earlier. Indian ovaries are going to stop producing oocyte 5 years earlier than our Western counterpart.
Yes. So I think that is a very important thing for us to consider. One. The second thing is regarding the luteal support. Don't you think that the luteal support is required only when we are giving gonadotrophin cycles? I think in clomiphene cycles and in the letrozole cycle, where you have only one follicle, majority of this of our studies, also the published studies, I would say, are saying that there is really no need for a luteal support, although it is debatable. But I'm asking you, would you like to give it for every patient of ovulation induction or IUI? Would you like to give progesterone? Because you're laying stress on the fact one progesterone only. I'm just asking you, one or none?
So I would, at the current state, I would give one progesterone only.
Okay.
Because if I don't give, and if the patient goes next cycle somewhere else, that doctor is going to criticize the hell out of me.
No,
and because people are not understanding that the role of progesterone. See, pregnancy has become an indication for use of progesterone.
Yeah.
As soon as the UPT comes positive, progesterone is written. Now, if I don't write, someone else writes, and they write 2233. So I'm at least one. Let us 14 days of one progesterone. Of course, we'll debate that no progesterone also one day.
Yeah, because basically for IUI, majority, I mean, there is really no need because there is a corpus luteum and there is only one follicle and one egg. But of course, if you have multiple produced with gonadotropins, of course, you're trying to improve your IUI success rate. So you're giving gonadotropins. With that, yes, you would require progesterone support, but not with a single follicle. I don't think so. Thank you.
Thank you. Thank you, sir.
Thank you, sir. I think it
Thank
was a
you.
fantastic session.
Obviously.
And the tips which you have given were really awesome. You know, I think they are the great take-home messages, and it is always learning when it is summarized in such a nice way. And Dr. Sonia, Madam, and Dr. Prerna, thank you so much for sharing.
Thank you.
Yeah.
Thank you. Thank you.
Yeah, over to you, Kalyani and Ritu.
Thank you, NM sir, for the wonderful insight and the wonderful topic that you covered today. And thank you, Sonia ma'am and Prerna ma'am, for chairing the session so wonderfully. Now let's move ahead to session 2, tackling adenomyosis and AIF cycles. I would like to invite our chairpersons, Dr. Roza ma'am and Dr. Sarita Agarwal ma'am. Dr. Roza ma'am, we all know she's the director of Olyai Hospital at Gwalior. She's also the board of membership committee Family Planning Association of India 2021 to 23, chairperson SBC Madhya Pradesh 22 to 23, representative board of trustees South Asia. She needs no more introduction. She is a well-known personality in all our FOXY meetings, and she has been the vice president FOXY 2014. Thank you, ma'am, for agreeing today to be the chairperson. We welcome you. Dr. Professor Sarita Agarwal, ma'am, she's professor and head of Department of OBGY, All India Institute of Medical Science, Raipur. She has been the Vice President FOXY 2015, ICOG Governing Council member from 2015 to 17, and even ICOG Academic Council member 2017. Chairperson for HIV Committee FOXY 2013. She has organized various workshops on HIV and AIDS about over 30 all over the country. Thank you, ma'am, for being here with us today. And I would like to hand over the mic to both the esteemed chairpersons to introduce our next speaker.
Well, thank you, Kalyani, for your kind words. At the outset, I want to congratulate Dr. Komal Chavan for doing such good academic activity along with Niranjan, a very close friend of mine. Komal, I wish you all the best for all your endeavors. I've been watching all your work that you bring as a chairperson as well. And I think this session with Dr. Asha Rao, a renowned speaker with endoscopy, and a topic which is very close to my heart as well, adenomyosis and the treatment and tackling, which is so difficult in infertility. I think all of us know Dr. Asha Rao, a beautiful speaker, Director Rao Hospital and Care, Coimbatore, Director for Postdoctoral Fellowship Program in Reproductive Medicine and Endogynecology, and is affiliated to Tamil Nadu, Dr. MGR Medical University, Chennai. Well, there's a lot of more to be said. She, of course, was a chairperson of the Endometriosis Committee of FOXY. She is at present. This is your last tenure, and you're doing such good activities. So wish you all the best. And I think all of us would like to hear from you because I know you're such a good endoscopic surgeon. And this is your field. This is your topic. Who better than you? Over to you, Dr. Asha.
Thank you, Rosa, for those kind words. I'm more of an ART specialist rather than endoscopy. I think my son has overtaken the field of endoscopy. It's a team
you have. You're so lucky to have a good team with you.
Yes. Yeah, thank you so much. And congratulations to Komal for having organized such a fantastic teaching program. So, and thank you, Komal, for giving me this opportunity to speak on adenomyosis, which is very close to my heart. I think my journey into adenomyosis started in 1992 when this girl who was married for 16 years and yet 34 years came to us with severe dysmenorrhea and infertility. And those days we did a diagnostic laparoscopy and it showed bilateral corneal block. And we did try hysteroscopic cannulation, which we had started doing those days and did not give any results, but the tubes looked apparently healthy. Uterus was about 12 weeks size. And this lady, we had nothing else to give but for Dinoges. And we stopped Dinoget at 16 weeks. This girl was lost for follow-up for a couple of months, and she comes back saying that I did not get my periods. And then we saw she was pregnant, and the girl child born in 1993 after stopping danazol. She got married last year, and it was such a happy occasion for all of us. And this wonderful medication, danazol, lost its popularity because of the severe androgenic side effects. And today, let me start my sharing my screen.
It's so amazing to know this young girl on Dynogest, and she did so well.
Not Dynogest, danazol.
Danazol. Oh.
Those days, no Dynogest in 1990.
Yeah, danazol. Great.
Danazol. Danazol was wonderful, very powerful, except that sometimes they, the little change of voice and acne. And so the androgenic side effects is what made us stop the danazol. And today we see that the incidence of endometriosis in the rise, and so is the incidence of adenomyosis. And this disease was historically diagnosed by histopathology at hysterectomy for very many years. The research on adenomyosis is almost 150 years plus. And in spite of so many years of research, we still have dilemmas in diagnosis and disputes in management. And all of us know the definition: benign invasion of the endometrium into myometrium, producing uterine enlargement with hypertrophy and hyperplastic myometrium. And the main symptoms are severe menorrhagia and dysmenorrhea in about 50% of patients. And though historically it was related to women with high parity and above 40 years, today we are seeing it more and more in the setting of infertility. So whenever there is recurrent implantation failure or recurrent pregnancy loss, please halt and proceed. Please screen the patient thoroughly for adenomyosis, look at the junctional zone, and see whether she has adenomyosis. Because many of the adverse problems of endometriosis, which we blamed endometriosis, seem to be because of adenomyosis today, which was not diagnosed. And the change in trend is that it is seen in younger women and infertile women, and diagnosed in 22% of infertile women less than 40 years undergoing ART. So this is a very important fact, because it's perhaps that we have shifted our fertile years to late 30s from the 20s, or it's also because the non-invasive diagnosis is easily available and more accurate. So we are seeing it more often, and combination of both. The true incidence is difficult to diagnose because we do not have histopathology confirmation. 20% of women with endometriosis concomitantly had adenomyosis. 28% of subfertile population has adenomyosis alone. And 54% of young women with infertility, dysmenorrhea, and menorrhagia could be having adenomyosis. So it's very important that we screen our infertile women for adenomyosis. And today's talk is about how can you tackle adenomyosis in the context of ART. So a recent meta-analysis demonstrated that adenomyosis is associated with decreased rates of successful implantation and increased rates of pregnancy loss, translating into an overall significant reduction in live birth rate. This is a beautiful paper by Tulandi and Younes in Fertility Sterility. And we also have earlier papers by Salim et al. In non-adenomyotic women, the clinical pregnancy rate could be 47%, ongoing pregnancy rate 45%, and with a miscarriage rate of 28%. Whereas in adenomyotic women, you see the drastic difference. The clinical pregnancy rate was 22%, ongoing pregnancy rate 11%, with a high miscarriage rate. This was in 2012. And we have some more papers from China also. You can see here, after ART, the clinical pregnancy rate, that is in blue, is much less in patients with adenomyosis compared to patients without adenomyosis. And the rates of miscarriage also are much higher in women with adenomyosis compared to women without adenomyosis. And this is a lovely paper by Conjero et al., which said that the implantation and clinical pregnancy rates, when studied in this context of egg donation, they saw that miscarriage rate was significantly higher in women with adenomyosis, though implantation was not effective. So when they did egg donation, so all eggs being equal, The miscarriage rate was higher in adenomyotic women, though they did conceive. So we have to not only get them pregnant, but also prevent them from getting preterm delivery. That's very important. And this is a wonderful paper by meta-analysis by Nirjanakis et al. In 2021, which concluded that adenomyosis can lead to poor implantation, poor placentation, leading to infertility, miscarriage, preterm labor, preeclampsia, IUGR, malpresentations, increased rate of cesarean sections, NICU admissions, placental problems, PPH, cesarean hysterectomies. All this, we can blame adenomyosis for. So it's very important to screen our infertile women for adenomyosis. Once again, a wonderful paper by Chakravarti group. There they studied women with endometriosis and adenomyosis compared to pure adenomyosis. And once again, the adverse effects of adenomyosis were confirmed. And adenomyosis is a disease of the junctional zone. Here you can see by 3D ultrasound, the beautiful endometrium, the myometrium, and this thin halo is a subendometrial myometrium, which is actually the junctional zone. And this is very important in fertilization. During ovulation, it causes contractions, which are from fimbria to fundus and from cervix to fundus, promoting the transfer of gametes. And after ovulation, the contractions quieten down, promoting implantation. But with destruction of the junctional zone or thickening of the junctional zone that you see in adenomyosis, there are irregular contractions, hyperperistalsis, leading to poor implantation and preterm delivery, reducing the live birth rates. So with adenomyosis, there are changes at all levels. The myometrium, there is myohyperplasia. The junctional zone, there is thickening, and the endometrium also has adverse effects. The factors which are favorable to implantation, like FOXO1A, HOXA10 mRNA, integrin, interleukin 10, etc., are decreased in the setting of adenomyosis. And the factors which are adverse to implantation, like macrophage, natural killer cells, interleukins, are all increased. So there are changes at the molecular levels also in the utopic endometrium. There is some problem with my. My slides are not moving.
You want to go back?
No, I'll just see why it is happening. Yeah. Yes. So there are changes in the utopic endometrium, the junctional zone, and the myometrium. And there are also changes in, the changes in the muscular layer may vary from slight localized expansion of the junctional zone to massive myometrial hyperplasia and fibrosis. It can change the plasticity and tonus of the uterus, as well as the contour of the endometrial cavity. And these are responsible for the hyperperistalsis, leading to poor implantation, preterm delivery, and all the difficulties of reproductive failure. And there is also progesterone resistance, decrease in progesterone receptors, molecular and immunological changes in the endometrium, and chronic inflammation. And all this lead to the various problems that we have already studied. And this is a wonderful paper by Hashimoto et al., where he has described all the reproductive dysfunctions because of the chronic inflammation and impaired uteroplacental perfusion due to adenomyosis. Once again, in the papers by Versalini, 32% miscarriage rate in women with adenomyosis compared to 14% in women without adenomyosis after ART. So once again, you can see here a beautiful picture, negative impact of adenomyosis on reproductive outcome. Anatomic level, enlarged uterus, distorted anatomy, cellular level, we have discussed already, increased junctional zone, all this can lead to reproductive dysfunction. So how do we manage? Most important is early diagnosis and later volume reduction of adenomyosis and the uterus. Both are very important. Earlier, we used to do a lot of diagnosis by MRI. If the junctional zone is thickened more than 10 millimeter, you can diagnose adenomyosis. And by 2D, there are various criteria, the globular asymmetric uterus, myometrial striations, So out of the 7 criteria, if you have 3 and more than 3, you can diagnose adenomyosis by 2D. These are the big adenomyosis uterus that you see by 2D. But my dear friends, I would urge you to diagnose adenomyosis like this at an early stage. Learn to do a 3D ultrasound and a color Doppler. And here you can see the endometrium, the myometrium, the junctional zone, and the early infiltration of myometrium and this is focal adenomyosis. Oh, again, there is some problem.
Don't make it slideshow.
No, now it's okay. Yeah. So color Doppler and 3D ultrasound both help you to diagnose adenomyosis early and learn to do it early with 3D ultrasound. So you can suppress the disease at an early stage with medication. And when these women come to your doorstep seeking ART, how best can you manage them? You have ART, you have medical management, and you also have conservative surgery. Conservative surgery was being practiced almost from 1952. But in spite of that, I would say there is not too much progress in this field because though there are pregnancies, you can have the complications of distorted anatomy, recurrence of the disease, and rupture uterus, which is a very big complication, which can happen in about 6 to 8% of women after uterine surgery. So you have more and more, we are trusting ART with medical management. Though there are no proper guidelines, when exactly you start medical management, how long you suppress, we are yet to make guidelines. So the medical management is, you can use, earlier we used danazol. We use OCP in young girls sometimes just for relief of pain, but they do not really do anything to the reversal of the disease. The friends in the ART clinic would be GnRH analog, Dynogist, aromatase inhibitors, intrauterine system with progesterone, and with ART paripasu. You can sometimes try non-surgical interventions like uterine artery embolization and HIFU. And how does adenomyosis work? It reduces how does GnRH work in adenomyosis? It reduces the expression of aromatase, cytochrome P450 in the ectopic endometrium of women with adenomyosis and endometriosis, decreases the expression of nitric oxide synthesis. And if you give it for 2 to 6 months, there can be a very good volume reduction from 180 ml to 86 ml as seen in the papers by Zhu et al. And another interesting paper by Tremelin et al. Where initially they used ultra-long downregulation for a short time, but later when they gave it for a longer time, they saw very good results, improved pregnancy rates in the setting of ART, and it also reduced the chances of PPROM. Some more papers by Stenokova and Tremelin. The rate of euploid miscarriage is increased in the setting of adenomyosis, but if you give a pre-ART GnRH downregulation, there is boosting of implantation. So implantation is increased. Plus, it may also improve post-implantation pregnancy health. That means it reduces the chance of preterm labor, PPROM, IUGR, and the various problems caused by adenomyosis. Once again, series of papers in the yesteryears, and I have been using GnRH analogs in our clinic almost from 2016, from 2006. So that is an experience of about 16 years. And more I have grown very fond of this. New et al. In 2008 found that long course of downregulation prior to FET significantly improved the clinical pregnancy rate, ongoing pregnancy rate, and implantation rate in patients with adenomyosis. So here you can see the pregnancy rate jumped up. That without GnRH was 24 and with GnRH is 51%. Implantation rate from 16 to 32% it jumped up, and ongoing pregnancy rate also improved from 21 to 48% with the use of long-term GnRH treatment before IVF FET. This is very important. And later there is a study by Nirjana et al. According to them, pregnancy rate may reduce when you use ultra-long control compared to short protocol due to prolonged ovarian suppression, because many times they have poor ovarian reserve because of endometriosis, multiple surgeries. So in these women, if you do a prolonged suppression, there could be decrease in pregnancy rates, increased cost, and decreased number of oocytes. So the answer perhaps would be to use a short protocol, do egg collection, and later give the ultra-long suppression for 3 to 6 months according to the size of the uterus. So suppress the adenomyotic lesion, suppress the uterine volume, bring down the uterine volume, and then you do the frozen thawed embryo transfer, and this gives you very good results. So it is advisable to segmental IVF cycles and administer ultra-long JNRH suppression prior to FET to improve the pregnancy rates. So again, this was studied in 2016. You can see FET with JNRH pre-treatment gave very good results of 39% compared to other groups, which is only 30%. So before FET, you give a ultra-long suppression. Once again, it's very important to reduce the uterine volume. And there is a paper from, lots of paper are coming from China, wonderful papers. This is from Siaku et al. They studied the association between uterine volume and pregnancy outcomes in adenomyotic patients undergoing FET cycles. According to them, if the volume is more than 98 cc before embryo transfer, the live birth rate is decreased to 25% compared to 43% when the uterine volume is less than 98 cc. Here you can see the live birth rate is 43 in group A with the uterine volume less than 98 cc and 25% in women with more than 100 cc, more than 98 cc. This is one of a, so it's very important to reduce the uterine volume prior to embryo transfer. This is one of our patients who had previous implantation failures elsewhere. You can see she had a subtle adenomyosis, not a very much enlarged uterus. And there's a lesion in the posterior wall. We gave her 11.2 JNRH depot. And at the end of 6 weeks, the suppression of lesion is minimal. At the end of 12 weeks, you can see that the lesion is very much suppressed and the endometrium is expanded beautifully, except for 2 small cystic areas. We did embryo transfer 16 weeks after the JNRH depot, and she conceived twins and with a live birth. This is another patient with, when you look at it, almost looks like DIE. This was a 4.7 centimeter posterior wall adenomyoma, irregular with some posterior adhesions. She already had a laparoscopy earlier and also a failed IVF. By 3D, you can see it looks almost like a myoma. And many doctors say that we want to do myomectomy, adenomyomectomy whenever I show this picture. It's almost impinging on the endometrium. Also has small, tiny chocolate cysts. So very tempting to do surgery, but what we did was, we did a collection, vitrified the embryos, and then we gave her a suppression for 4 months with 11.2 and 3.7 JNRH analog. And then we did the embryo transfer, and today she is a happy mother of 3-year-old child. How about Dinoges? Dinoges is a wonder drug of the decade. It's very good for the management of dysmenorrhea, dyspareunia, and chronic pelvic pain associated adenomyosis. Though the GnRH analogs are superior to Dinoges for controlling menorrhagia and also for reduction of uterine volume. This is what we have seen over last 16 years, from 2006 to 2023. This is the 17th year of use of GnRH. A study by Matsushima et al., where they compared GnRH analog, low-dose estrogen progesterone, and Dinogest over a period of 16 weeks. The uterine volume came down from 307 cc to 177 cc in the GnRH analog group, whereas with estrogen progesterone, OCP, and Dinogest group, there is no change in uterine volume at all. So the volume reduction is much superior by GnRH analogs. Today, in resistant cases, you can use aromatase inhibitors. You can use letrozole 2.5 milligram twice daily. It reduces the symptoms of adenomyosis and also gives reduction of uterine volume. And if you combine GnRH analogs with aromatase, you may get almost a reduction by 60% as observed by Kimura et al. After 8 weeks of treatment. And it causes reduction of uterine volume and also causes reduction of adenomyoma, just like the GnRH analog. The green is the letrozole group and the red is the GnRH group. Both are almost parallel. And this is another paper by Scarpellini et al., where they compared aromatase inhibitor plus GnRH analog versus Dinogest group in women undergoing IVF. Pregnancy rate after the combination was 48%. There's aromatase plus GnRH analog suppression compared to Dinogest group, which was 20%. So you can see which is superior. This is one of our own patients who came during the COVID year. She came, in fact, in 2019, November. You can see the large adenomyoma, which is 7.5 into 4.4 cc with a uterine volume of 344 cc. The normal volume of the uterus is about 50 to 60 cc. And this is like a 12-week size uterus. And she had an AMH of 1.2, male factor being normal. Uterine size was 12 into 6.4 into 8.3 with diffuse adenomyosis. Already had laparoscopic treatment for endometriosis earlier. So this lady with the low AMH went in for antagonist protocol, collected the embryos, vitrified them in November 2019, maybe in December. And in February 2020, with a uterine volume of 344 cc, we started suppression of the adenomyosis. We did it with 11.2 doses, plus another dose of 3.75. That means we suppressed her from end of Feb to September, almost 7 months, along with letrozole 2.5 milligram twice daily and norethistone 5 milligram. This is to prevent the bone loss. Whenever you use GnRH analogs or letrozole, you have to use norethistone acetate to prevent the chance of losing bone mineral density. So the uterine volume came down to 204 cc. So October 2020, we did the embryo transfer after 7 months of suppression. She conceived a singleton. You can see early pregnancy, it's like that bug burrowing in the sand. A pretty large adenomyosis, and early pregnancy, it's quite frightening. I was worried whether she will go into preterm labor. And this is at 12 weeks, 11 weeks, 6 days. The adenomyosis is actually thinning out. This is one of the prognostic factors. If the myometrium starts thinning out, the chance of preterm delivery would be much less. And this lady went to 37 weeks. She had a cesarean section at 37 weeks. And this was in 2021. And she's a happy mother. How about Mirena? For a long time, we did not use intrauterine device because we were worried that it can have ill effects on the endometrium. But today we know that it can give you an additional success points. It acts locally and causes decidualization of endometrium and adenomyotic deposits, reduces the local prostaglandin production within the endometrium. It can be used along with GnRH analog. So the volume reduction by intrauterine device as per se may not be great, but it seems to reverse the local adverse factors in the endometrium and the junctional zone. And here you can see this is a beautiful paper in 2019 with LNG-US group. The implantation rate was 32 and pregnancy rate 44. And ongoing pregnancy rate is 41 compared to the control, which is much less. So today you can use intrauterine device also along with GnRH analog for rapid reduction of uterine volume plus improving the implantation. Especially some women who have thick endometrium, you can use GnRH analog plus intrauterine device, and patients do very well. There is a rapid recovery of the endometrium and there is no thinning out of the endometrium, whereas the cystic changes will regress. What about uterine artery embolization, the non-surgical intervention? We know it avoids a major surgery, but in terms of fertility, you can have occasional ovarian failure, amenorrhea, fistula formation, increased rate of miscarriage, IUGR. So it was said to be not suitable for women with infertility. But today, there is a lot of research going on. This is a wonderful paper from UK, 2023. And according to them, the pooled rates of pregnancy was 39%, live birth rate 69%, and miscarriage rate was only 22% following uterine artery embolization. So it could be a viable alternative to hysterectomy in achieving symptomatic relief while preserving the uterus and preserving the fertility potential. I think we need some more RCT before we impinge on this, but seems to be emerging out as one of the factors to help women to preserve the uterus. And HIFU, again, initially we said it's not for women with fertility problems. Today, once again, there are some more papers coming out of China which say that you can use HIFU and they can have pregnancies. So some more RCT. So today, I have spoken a lot about the medical adenomyomectomy. So where you can have almost a 60% reduction in the uterine volume by GnRH plus minus aromatase. So what is the role for surgeons? That's what my young surgeons are asking. Who will benefit from uterus sparing effect in sparing surgery in adenomyosis? Large adenomyoma, up to 12 weeks, I think it's very good with medical management. But if you have large adenomyoma, much bigger uterus, a history of recurrent miscarriage or recurrent implantation failure after IVF, in spite of medical suppression, not responding to medical management. This is the statement which you have to underline. Recurrent miscarriage or recurrent IVF, where you're suppressed with long-term GnRH and you did not get results. This is the only case that you have to go in for surgery. Do not rush for a surgery for a focal adenomyosis of 2 centimeter, 3 centimeter, because it's not required. They can do very well with medical suppression. And with surgery, many times it is wedge resection. Today, there are very many methods coming up. The disease can recur rapidly because if the disease is not removed completely, there is no proper capsule. So recurrence is common, pain will return again, and you have the chances of rupture uterus. So there are results following adenomyomectomy, but one should always remember the possibility of rupture uterus. You have to wait for 8 to 12 months, according to this paper in 2018, prior to doing IVF. You cannot rush for IVF after 3 months. So if you do a medical adenomyomectomy, the way I told you, you may suppress for 2 to 6 months. If you do a surgery also, you will have to wait for 6 to 12 months for complete healing. And if you do a medical adenomyomectomy, you do not have the fear of rupture uterus. You can see here the paper by Tan et al., which shows that the pregnancy rates improved, focal 52%, diffuse 34%, miscarriage rates were around 21% in these women, and uterine rupture after a adenomyomectomy for diffuse adenomyosis could be almost 6.8%. After a cesarean section, the ruptured uterus chances are 1 in 1,000. After a myomectomy, it could be 1 in 100, but after adenomyomectomy, it could be 6 to 8%, especially with a lot of young surgeons going around. But if you do not do a proper resection, everybody is thrilled to do a 2-flap technique, 3-flap technique, 4-petal technique. You imagine beautiful petals, but it is not as simple as that. You can have complications. So according to the master of adenomyomectomy, that is Osada, if it is focal adenomyosis, you can do a laparoscopic surgery. But if it's a diffuse lesion, large adenomyosis, he says it's worthwhile doing a laparotomy in adenomyomectomy. So when young women come to you, maybe the last few slides, come to you with, is it okay for me to take another 3 minutes?
Yes.
Yeah, please. Yeah, you can summarize that.
Yes, yes.
Okay. So when they come to you with infertility, treat them like anybody else. Do a routine infertility workup. Help them sometimes. Maybe they conceive naturally or by IUI. And if they do not conceive, surgery is not taken into consideration before ART. Give a long suppression by GnRH and lock. Do ART. Embryo transfer 3 to 4 times. And if there is no success, or if there is severe menorrhagia or dysmenorrhea, that is the only time you go in for surgery. And we had a nice paper in 2016, 56 patients with medical treatment, 44% pregnancy rate, and live birth of 68%. This is one of our patients with a posterior wall 6 centimeter adenomyosis, and after GnRH in the log, she had twins born. This is another patient who had a previous adenomyomectomy elsewhere. She also had an IVF failure. She came with 6 centimeter posterior wall adenomyosis. This is in 2006. We suppressed her for 6 months with 11.2 depot, 2 doses, and then she had embryo transfer, and she had twins and live birth in 2007. This is another lady who had married to her uncle, multiple losses because there was marriage in the same blood, came to us asking for egg donation at 41 years. She had a large adenomyoma. She underwent egg donation, embryo transfer 3 times. And the 3rd time she had a miscarriage. And she ran away when he told her adenomyomectomy. She came back after 1 year and she underwent adenomyomectomy. And later IVF, she conceived and delivered twin girls in 2008. And this another girl who had posterior wall adenomyoma removed. Adenomyoma is the cystic lesion, and it's very much amenable to surgical correction. So if you see a cystic lesion like this, do not go on suppressing her with GnRH. Do a laparoscopy, drain the cyst, fulgurate the wall, and give GnRH. And this lady promptly conceived after stopping the GnRH, and she had a live birth. So this is a study by Duhom et al. In 2018. If it is a slight disease, You want to do ART, standard 2 to 3 cycles of ART, cryopreservation, and transfer 1 to 6 cycles according to them. And sometimes if the cysts are close to cavity, you can do a hysteroscopic treatment, GnRH for 2 to 3 months, and then do the embryo transfer. So they never mention adenomyoectomy, even if the uterine size is moderate or severe. So dear friends, manage as much as possible with medical management, because coexistence of adenomyosis and endometriosis can have very significant impact on infertility. Pre-treatment with GnRH appears to be beneficial in improving the pregnancy rates and improves fertility outcomes. The benefits of fertility preserving surgery very gratefully, to be performed only in selected patients who have severe pain and not responded to medical management. Thank you all. And thank you, Dr. Komal, for this wonderful opportunity.
Well, thank you, Asha. You, as always, well spoken, to the point, and I think you go for more of medical management, and your experience with GnRH analogs are much better. And the take-home message would be, if you're a good laparoscopic surgeon, then go ahead with it, if there need be, as the case is. That's a good message. Any questions, or we can move on? Okay, I think it was crisp, to the point, no question. Ritu, you want to go ahead?
Yes, ma'am. I want to ask Asha, ma'am. Ma'am, what is your go-to therapy? Like, what do you prefer, just GnRH analogs alone, or would you prefer giving it with letrozole and GnRH analogs? I mean, what is your personal choice? Because you've done so many cases. So it helps me to understand what I could do better in my practice.
Yeah, my personal choice is to give GnRH alone. And most often they respond very well to 11.2. You can give 1 dose, or you can give 2 doses, suppression for 6 months. But if there is no improvement in 8 to 10 weeks, or at the end of 11.2, 3 months, I would like to add these days aromatase inhibitors. If the regression of volume is slow, then you can add aromatase. But the choice would be otherwise for a single drug. GnRH analogs.
A lot of people just do egg retrievals, freeze all, create embryos, freeze all, give just leupride in that 1 month and then transfer in the next month.
Yes, if you have a small focal adenomyosis, there is no need to go for a 3-month suppression or 6-month suppression. We went in for 6 months suppression because the uterus was about 12 week size, 344 cc uterine volume. And she came down to only about 200 cc. Beyond that, she wouldn't come down. At the end of 7 months. We had to do a transfer because it's a large adenomyoma. Otherwise, you can do very well with the maybe 11.2 for 8 weeks, 12 weeks. Today, there are papers coming up which say that the uterine volume has to be between 50 to 100 cc. And there are also papers which say that the junctional zone has to be brought down to 5 millimeter. But I have not made a study to that extent. So I think there is more research going on. I'm sure in another 6 months or 1 year, we'll have many more studies coming up.
Thank you, ma'am.
Can I ask you? Can I ask? Can
Yes,
I ask
Dr. Sonia.
Hi, Dr. Sonia.
Good to see you, Dr. Sonia. Please go ahead.
Hi, Rosa. How are you? Very, very good to see you.
Yeah.
Asha, brilliant as always. Very, very good. What is your, when do you select Dynogest as a molecule when you're treating adenomyosis? What is your criteria for that? Or do you use it
I
at
give
all?
Dynogest to women who have completed their fertility.
Okay.
She has had a childbirth and she does not want intrauterine device. And then I would give her a Dynogest. And sometimes you put an intrauterine device and she says, complains, nuisance pain here and there. You give Dynogest for a couple of months, they are fine. Or young girls come to you with dysmenorrhea and you know that they have a mild adenomyosis. You give them Dynogest for a couple of years until they want to get married, they are fine. But for a rapid volume reduction, nothing like GnRH analog. And if the volume is high, then you give the second drug, that is aromatase.
So suppose it's the junctional zone only that is thick. The volume is not that big. It's a diffuse kind of a thing, but it is close to your 94, 93. Then what do you do?
GnRH analog.
GnRH, still GnRH. Okay.
Yeah.
That's interesting. Yeah, that's very nice. Thank you so much. Thank you.
Because RCTs are supporting that.
Asha ma'am, Kalyani here. I also had a question. Like you mentioned that normally we do the IVF, freeze the embryos, and then, do the down regulation and then plant the frozen embryo transfer. But when we get the patients who have already had the IVF failures, probably they are not ready to repeat one more IVF failure till we give them the satisfaction that, the volume reduction has happened. So like if we do this long 11.25 with the letrozole, we make the reduction. Post that, if we do the IVF, have you seen like are the embryos or are the quality of the oocytes or anything getting suppressed?
Come again? I mean, no, it was not clear your question.
So, ma'am,
She's not creating embryos before down regulating. Like she's not creating embryos before giving leupride. She's giving leupride before she creates the embryos. So does this make a difference in the success rate? Do you recommend creating the embryos before giving leupride, or do you say that it's okay to first?
Yeah, about 4 or 5 years back, when we did not know about this, doing more and more of frozen transfer, we have given suppression initially, and after 12 weeks of ultra long suppression, like anybody else. When Salam said you do ultra long suppression, we did ultra long suppression. And then we saw that the oocyte numbers were less. We got maybe 3 oocytes, 2 embryos, but they're still implanted. So today we say that do initial egg collection, vitrify the embryos, then go in for a long suppression, because the ovaries do not get suppressed. So,
right. So I guess we need
suppression
to,
and then do the transfer.
Also, what I feel
that also fails, and if the ovaries are very small, then you should consider doing even an egg donation, because it's much better than doing surrogacy or even adenomyomectomy.
Also, ma'am, sometimes then the trigger also doesn't work, right? If the suppression is too long, also that is also the problem that we have faced. If the suppression is too long, so that is also the problem. So we have to be careful about that also.
If you give a long suppression, then you wait till the menstruation starts, perhaps, in case of poor ovarian reserve. If you have a good ovarian reserve, then the story is different. So everything depends on the ovarian reserve.
Ma'am, can I ask a question?
Yes, please, Nousheen, go ahead.
Asha ma'am, what is your experience about Mirena use concurrently with the leupride depot? I mean, how many months of washout period? Because unlike the other drugs, this is a progesterone, which can have an impact on the implantation. How many months of washout do you practice? And at what stage you actually put Mirena? Because there's a high chance of getting it expelled also.
We do not give Mirena to all. We give Mirena whenever the uterine volume is high or the first transfer has not succeeded. Then you give gene, and the endometrium is thick in some patients. They have a polypoidal endometrium along with adenomyosis. So such patients do very well with the Mirena. And whenever you put Mirena, you should keep at least for 12 to 16 weeks. And the washout period, they do very well if you wait for about 3 weeks. Not longer than that. Whenever you give a progesterone, there is no problem at all. You remove the Mirena and I wait for about 3 to 4 weeks. And after 1 month, you can start the embryo transfer procedure, and they do very well.
So, ma'am, she will be under suppression plus you put Mirena when you, that's how you plan. Like, or you give the suppression.
Yes, because I would have collected the embryos already. Yes.
Right. Okay. Okay, ma'am. Thank you so much.
Okay. Yeah, thank you. There is no endometrial damage. This is what I'm trying to tell you.
Right.
So,
thank you.
Can I just ask one last question? I know we are running late, but ma'am, have you faced challenges building the endometrium after such long suppressions? I mean, does the endometrium build well with the HRT?
I saw this more in a couple of patients who have had previous adenomyomectomy elsewhere. With the adenomyomectomy, maybe they went a little deep and there would have been a damage to endometrium. It was very difficult to bring up her endometrium from 3 to 4 millimeters. Because you do not know where to stop. You go almost up to the cavity and then you have the problem. And hysteroscopic treatment also is being tried nowadays. So perhaps you do a hysteroscopic excision of the adenomyoma. You can do it in a focal adenomyosis, which is close the cavity. But you do a larger excision, then maybe the endometrium gets affected. Most patients somehow have a good endometrium in spite of adenomyosis.
Thank you, ma'am.
Thank you all.
Finish. Asha, thank you so much for patiently
Enjoyed the evening, and thank you, Roza and Sonia and all my friends.
Yeah, thank you, Komal. Thank you. It's a lovely program. So over to the coordinator.
Thank you, ma'am. Thank you, Roza ma'am. Thank you, Sonia ma'am. And thank you, Asha ma'am, again for a wonderful talk. I always enjoy your talk on adenomyosis. I would now move on to the next session, and that is the panel discussion on repeated IVF failures. And today, Dr. Kundan has sent his apologies that he will not be able to join us because he's, occupied with some surgery and unable to get out. But our second moderator is Dr. Erika Patel, who's a very good friend and a scientific director at Art Fertility Clinics in Chennai. And she is an executive committee member at TAPASAR and a chairperson of Organ Donation Committee of the IMA. Welcome, Dr. Erika. Would you please take over the session and introduce your panelists? Thank you.
Thank you so much, Ritu. Can I have the next slide? Let me introduce my amazing panelist. First, Dr. Shrutika Thakkar. She is a medical director at Medansh Multi-Speciality Hospital and Medansh IVF, Mumbai. Dr. Brajbala Tiwari. She's a consultant gynecologist and infertility specialist and credential menopause practitioner. She's a managing director at Life Care Hospital, Indore. Dr. Nisha Pansare, she's a consultant gynecologist and fertility specialist at Nova IVF, Karadi, Pune. Dr. Sheetal Sawankar, director at Avisa IVF and Fertility Center, Mumbai.
Hi.
Dr. Yuvraj Jadeja, medical director at Nimaya Women's Fertility Center, Vadodara. Dr. Nousheen, Director and Senior Consultant in Reproductive Medicine, Kraft Hospitals and Research Center. And Dr. Dhaval Baxi, Gynecological Endoscopic Surgeon and Fertility Specialist at Disha Fertility and Motherhood Hospital, Indore. Welcome to all the panelists. And first of all, Asha ma'am, your lecture was just amazing. And now I don't think I'm going to put on the case for adenomyosis because I think all of you are going to answer. It. Can I share my screen now? Is it visible?
Yes, ma'am.
So when Dr. Ritu gave me this topic, she called me and told me that you have to talk on repeated IVF failures. And I said, yeah, maybe I have done it on RIF. And she mentioned specifically, no, it is repeated IVF failure and not RIF. So let's get into the difference between, what do you think is the difference between RIF and repeated IVF failure, definition-wise, Dr. Sheetal?
So implantation failure is basically failure to have clinical pregnancies after putting good quality embryos. That is, if you put in 4 good embryos or 2 blasts in frozen or fresh transfers, and the age is also a criteria. IVF failures can be even biochemical pregnancies, is what I feel, that even if patient has biochemical pregnancies, the patient is not conceiving. I think that is the major difference, is what I feel.
Yes, so I feel when we talk about repeated IVF failures, we consider everything that has gone wrong, starting from the stimulation or probably So moving on to IVF is someone. I don't know why I'm doing this. So moving on to the definition of RIF, because RIF constitutes most of it within repeated IVF failures. And what do you think is the definition? How do you define RIF, Dr. Shrutika?
So RIF is basically at least previous 3 failed attempts after transferring at least 4 good quality embryos. So that is what is RIF, where there is failure to achieve any pregnancy, even in spite and despite of having great embryos.
So there were a lot of controversies about the definition of RIF.
Yeah,
but
3 or 4 is...
So a very interesting take on this, it is a paper in Fertility Sterility, where eventually they say that the term recurrent implantation failure should be a very functional term only to guide further management. And they suggest that RIF should not be called until implantation failure becomes reasonably likely to be caused by factors which are other than embryo aneuploidy. So we can keep on transferring embryos without checking whether they are euploid or aneuploid, and then we keep terming it as RIF. So here they are trying to say that unless and until you know that embryo is not an issue, up until then you should not term it as RIF. So let's move on to the first case. She's a 34-year-old female, underwent IVF after 3 failed IUI cycles. Husband 37 years, normal semen analysis report. 9 oocytes retrieved. They froze it on day 3 and transferred 2 in a fresh cycle, beta HCG negative. FET was done after 3 months in an HRT cycle, again negative. What would you do next, Dr. Nisha?
Yeah, in this case, patient is RIF, what I consider here. So we can think about considering uterine cavity first. We'll go by uterine causes, embryonic causes, and any other factors involved in it. So definitely there are no investigations about uterus. So we need to talk about uterus cavity, if there are any fibroids, any good 3D ultrasonography will guide us about that, and any issue of hydrosalpinx, and endometrial cavity, as in the volume, thickness of the endometrium, and blood flow to the endometrium. So RIPI we have to consider in this case. And when there are repetitive IVF failures, so definitely hysteroscopy plays a role to rule out all uterine and anatomical causes.
Was it IUI, multiple IUI failures, right? It wasn't multiple.
No, IVF also.
IVF also.
Yes.
So, first of all, Erica, I think we have transferred cleavage stage embryos here. So
you are on mute, Dr. Shrutika.
Shrutika, you're not audible.
Yeah, we have only transferred twice in this case, and that to cleavage stage embryos. So I think it's a bit premature.
Shrutika, no problem in your network.
I said there are only 2 cleavage stage embryos that have been transferred so far, right?
Yes.
And only 2 attempts of embryo transfer have been made. So I think this would be a little premature to call it RIF.
So do you do, Dr. Yuvraj, do you do hysteroscopy for all patients? What is your opinion on hysteroscopy for all IVF patients?
So, I am a pro hysteroscopy person. I mean, though we know the evidence is a little bit deficient in terms of the role of hysteroscopy for IVF hysteroscopy in all patients, but I consider hysteroscopy as one of our aspects. About this, I would definitely go for a hysteroscopy.
So when we talk about hysteroscopy prior to IVF, it is associated, there are multiple studies that have come. There are a large group of studies and an RCT that has been done, which proves that hysteroscopy prior to IVF does help. However, in practice, many of us do not do it for each and every patient, and we probably end up doing it after one or maybe one failure.
I feel if a good 3D ultrasound is done, it should be good enough for at least a first timer. If it doesn't work out, maybe then definitely there is a problem. You can go ahead with an hysteroscopy and then.
Coming to sperm DNA fragmentation for this patient, what is your opinion about it, Dr. Nousheen?
Well, generally sperm DFI testing I don't do as a routine. But in case of RIF and RPL, I would prefer doing it. I mean, the evidence is more in case of RPL, but even in RIF cases, I prefer doing it simply because of the fact that it actually gives a cue for a correction method, like some lifestyle changes, some antioxidants. So it acts as a prognostic indicator, though, but then the large evidence says that even though the sperm DFI is high, even after, despite all the treatment measures, still the outcome is same. So though it has a role, the outcome is still unchanged, but I would still do that.
So at what point, in which patients do you do it? How many failures? Is there any protocol that you follow?
So DFI is generally done for patients who are smokers, male age more than 40, those who are having varicocele, those who are having RIF, RPL, or any chronic medical conditions.
Would you prefer surgical sperm retrieval for patients like this?
We used to do the surgical, earlier we did a study. In fact, we compared one group with the TISA and the second group with the normal antioxidant, and the third group with MAX. And though we found that the pregnancy rate was better with the testicular sperm, but finally the miscarriage rate was same. So as I mentioned earlier, though it has a role, final outcome is all coming to be same. So what I felt is the current measures are not actually very effective. We might come up with some newer techniques of sperm selection.
I think sperm sorter is something that we can think about. So we have been using something like policies now.
Magnetic sperm sorter.
Yes.
We've been using it, but finally it's not giving any statistical difference. Finally, what we want is evidence, right? So evidence is not strongly suggesting for something like that. Though Sandro Esteves, as Dr. Erika has mentioned, is a strong proponent of TISA for testicular sperm extraction and doing it for high DFI patients. It's largely from one group. So, it's too early to make it as a routine for everyone, especially since it's invasive.
Yeah, I think TISA should be the last resort. We should
resort.
first give antioxidants, repeat DFI first after 3 months. And then if the DFI is still high, then we think about the surgical sperm retrieval. Also, non-centrifugation methods. Sheetal and Nousheen both mentioned MAX. But in fact, when we are doing MAX, you are centrifuging the sperm twice.
I was talking about the sperm sorter, Shrutika, not MAX.
Sperm sorter actually makes more sense. So
Yes.
having a non-centrifugation method will be better for the high DFI sperm, because then you are not causing injury by whatever treatment you are doing.
Right. I agree on that.
So even like you said, Sandra Esteves, even the review article was published in 2022, where even they are concluding that the data still remains very limited in doing surgical sperm retrieval in non-azoospermic males. And it should probably be really, really confined to people who have repeatedly proven DNA damaged sperms in their ejaculate samples. And only in those cases it should be done. Like Dr. Sheetal mentioned, we can select lesser DNA damaged sperms in ejaculate samples by multiple other techniques rather than collecting testicular sperm. Moving on to, would you do a parental chromosome analysis, and should it be done in this case? And would you, or if not, then which cases would you do it? Dr. Brajbala, do you do this in your practice?
Dr. Brajbala, you are on mute.
Yeah, good evening. So if we are very sure about the good quality embryo, day 5 blast is there and a very good quality endometrium is there, everything we have ruled out, then particularly more than 35 each, I would, if there is nothing left, then we will go for chromosomal analysis only.
Can I have opinions from everyone? Actually, do you do how often do you do parental chromosome analysis? In which cases?
For all RIF and all RPL cases,
RPL,
I'm doing
yes.
parental karyotyping. Because as per the recent X-ray committee opinion also, one of the they have this traffic light system of green, yellow, and red. In that, the parental karyotyping is considered. It's a considered one. So we do it, though it is the positivity might be very less, maybe out of 3 to 5% out of the entire population. But if it is positive, then the normal IVF protocol may not work for them. They might have to go for PGT.
So actually PGT mandates, if you want to opt for PGT, I think parental chromosomal analysis is a must. So that is the first step before you do PGT. So that is why I think all of us will agree to do karyotype.
Right.
So like you said, the incidence of translocation carriers in couples with recurrent pregnancy loss as well as RIF both is 4.3 to 5%, which is approximately 4.7%. And it should be performed in couples, and definitely it is a prerequisite for PGT. So since we mentioned PGTA, what is your, I mean, keeping the law 1 second aside for only theoretical purpose, if given an opportunity, would you do PGTA for all?
Not for all patients, but definitely RIF patients. Now it is indicated. They have said that medically indicated patients, you can do PGTA. So I think they are indicated, and you should do PGTA in these kind of patients to figure out what quality of embryos. Because if you're putting in good morphological embryos, and if the embryos are not implanting or the blasts are not implanting, I think it makes more sense to do a PGTA and figure out what's wrong with the embryos.
Anyone else has a differing opinion on PGTA?
Well, I have a differing opinion because, PGT is there since I think some 10-15 years. We have this PGTA, one era of, the Esteem trial, Rubio trial, now with the latest NGS platform, the STAR trial. All of them universally shows that there is no difference in the pregnancy rate. And it is simply, even the NEGM 2015 article showed that when they transferred this mosaic embryos, 18 patients with mosaic, they had a healthy live-born baby. So one problem could be that most of the mosaic embryos might have undergone autocorrection. So when we are rejecting them, are we really rejecting them? They might have a potential to autocorrect. Second thing is that what we are biopsying may not be a true representation of the trophectodome, of the embryo potential. Third reason is that, even I have read an article in First Third where they mentioned that even the biopsy technique can cause a harm to the embryo and can even alter the results. So altogether, I strongly feel that though we have this in-house PGT team since 14, 15 years, we are not doing as a routine, mainly because only for those patients who are actually PGT indicated, just like the law.
No, it is not for all, Nousheen. I just said for RIF patients.
Not for RIF also.
I said for only RIF patients, not for all.
Even in my opinion, not for RIF also. Only if there is any chromosomal variation seen, then only I recommend because of these reasons. I mean, this is my viewpoint.
And it is not even chromosomal abnormalities. If they are there, then it is not PGTA, right?
So, so it's actually a debate. I mean, it's everyone have their own viewpoint, but the reason is because of all these points which I have mentioned about the autocorrection and then whether it's a true representation and the harm. And another thing is that many patients, if you actually put to PGT, less than 50% actually get 3 biopsyable embryo. So whether it is worth to do PGT or you transfer them, especially in case of advanced stage where it is actually required, is also a question. Like, you might finally end up a stage, you push them all to day 5 blasts, and then you might not even actually end up having a good blast to transfer.
Okay, so I am a coordinator. This is turning into a debate about PGT, but this is a topic which is very, very close to my heart. I can't really control. So the thing is, Nousheen, if the fact that your embryos are not going up to day 5 and you're not being able to biopsy them, maybe that's the reason why it is not happening. That is the reason maybe you're getting an implantation failure, one. Second, I feel that in recurrent implantation failure, PGTA has been giving a lot of us good results.
Okay. Absolutely.
Yeah. And
agree, Ritu.
I cannot deny the fact that it is an invasive procedure. However, we do have non-invasive PGTA which is available to us now. But at the same time, I think if it is done by a good embryologist who's got like a good technique, the damage, I'm not saying it is zero, it is zilch, it is minimized. And I really feel that the risks of doing PGTA are, when you compare the risk versus benefit of doing pre-implantation genetic testing in a patient with RIF, I think the benefits kind of outweigh the risks of doing it. And I would definitely do PGTA for patients who have actually gone multiple implantation failure, because that is the most scientifically backed technology which is available in today's date, where I can do ERA, where I can give adjuvants, where I can give a lot of other
not so scientific technology can be offered. I think PGTA trumps it by being scientifically backed.
There, I agree with all your emotions and then the sense of, entitlement for PGT. But then, there's no difference in the pregnancy rate, in any of the studies.
Absolutely. Let me stop you right here. Unfortunately, I don't have the NEJM paper. It came out in November 2021. I don't have it here in my PowerPoint. But if it is very mandatory these days that we critically analyze every paper that comes, just because it is a New England Journal of Medicine, we cannot accept it. If you see the paper, when they have compared PGTA and the pregnancy rates, the first and the biggest flaw is that they have taken day 3 and day 5. There itself, there is a huge bias where you cannot take day 3 and compare it with day 5. And secondly, their endometrial preparation techniques as well as the progesterone on day of transfer is also. So there are a lot of critical reviews about the NEJM paper which proved there is no difference. Secondly, coming to mosaicism, like you mentioned, that is something that even I wanted to touch. Have you heard of something called as here? That's what I was coming to. If this patient, we have 5 good quality, top quality blasts, PGTA done. We have 1 euploid, 1 aneuploid, and 3 low mosaic embryos. We transfer the euploid and the patient is negative. So tell me, would you go ahead and transfer the low mosaic or consider transferring the low mosaic embryo?
So people who are saying, promoting PGT, whatever, I've spoken to them and they have said that whenever you're transferring, you first have to only transfer the euploid. And then if it doesn't work out, then you can transfer the mosaic embryos also. That is the chance that you're supposed to take. And you're supposed to tell the patient that that is the risk that you are supposed to take. But then that is what we do. But the thing is that when the patient is suffering from RIF, do you have a choice? As it is, the patient is frustrated. You have to try something. If the patient wants their own genetic child, what option do you have? You have to try something. You can't just sit, not do anything. So if you're trying everything, PGTA is an option. I feel that is an option.
Have you? So coming to this question,
all the adjuvants that we are doing, what is proven? I don't know. There are so many things that are not proven, but we are trying everything. It's just like that.
Can I?
No, I think this is turning into a debate on PGTA.
I think Yuvraj wants to say something.
Yes, Yuvraj. Yes, Dr. Yuvraj.
For a long time, we should hear him.
Yes.
All right. So,
Okay.
Dr. Nousheen is quite correct. Most of the papers definitely shows that, all right. And in fact, coming back, the most recent paper, if I don't know, all of you have read about OSS fertility, Durga Rao, where she compared recurrent implantation failures in 3 categories. One was PGS alone, one was PGS with ERA, and one was nothing. And again, they proved that all the 3 didn't have any statistical significance. But saying all this, as Dr. Erica mentioned, evidence and papers are to be taken with a pinch of salt. If you're going to talk about evidence, we should start doing everything. TISA does not have any evidence. DFI
Right.
does not have any
Absolutely.
evidence. Right? So one thing is that. But logically speaking, where PGS is concerned, I think as of now, in patients of recurrent implantation failure, we could use it as a choice of selection, maybe the choice of rejection. All right. So then it comes to the question of what you've put forward, where you have an aneuploid, you have a low mosaic, and you have a euploid. So of course, your entire focus would be to transfer a euploid embryo first. Now coming back again to your question of whether you would want to transfer a low mosaic. Well, in this case, no. Because she is not a poor ovarian reserve patient. She's not a patient where she's like 40 years and 45 years old, where she's running out of time. Ideally, you could still do a cycle in her. And this is what is scientifically we should do. Then, of course, taking a consent and taking a risk and transferring a low mosaic. Remember, mosaic is a 5 to 10-year-old concept. We don't know what a mosaic child 25 years is going to be. We have to be very aware of it. There have been papers that said mosaics will have high autism, whatever XYZ reasons. So at the end of the day, mosaic is still a mosaic. You can argue around it, but it's not a euploid. So in an RIF patient, euploid as PGT as a method of selection is definitely something that majority of us now do and consider something that we would want to do. Where a rejection is concerned, where you don't want to do another cycle, you want to throw a mosaic or not is debatable, is between you, your patient, and the genetic counselor.
Can I add on?
Yes.
Yeah, I mean, I agree with him. But in case if the after, the key part, as he mentioned, after counseling the patient, if the patient is insisting or want to try, still, I think because you mentioned it is low mosaic, after explaining the patients about the risk and the long-term implication, as per the evidence, we can transfer, because it says that if less than 50% of the cells are enucleoid, you still have a chance of getting a healthy baby. As per this NEJM article, as I was mentioning, about 18 patients, were transferred, and they had some 5 healthy babies of mosaic embryos transferred case. But I would say in those cases, we have to do a close follow-up and do an NIPT or amnio just to make sure that we are dealing with a healthy baby. But again, it's all about the counseling and what the couple choose.
Yeah.
Thank you so much. So here, this is where,
which tells you if what chromosome is involved and how to counsel the patient accordingly. So you have to follow, when you get a low mosaic embryo, you're supposed to follow that chart and study which particular chromosome mosaicism is involved. And then you also get a better idea, because if it is chromosome 22, 23, then you're not supposed to transfer it. If it is chromosome 9, 12, then you can still offer the transfer, of course, after counseling. So there's a beautiful chart. You can Google it. It's online available. So if you still want to go ahead and transfer the low mosaic, it's the chart that you should refer to while counseling the patient, keeping in consideration which chromosome is involved.
Thank you so much. So here the thing is, all the arguments are excellent, but provided this mosaic was actually a mosaic, and this is where I come to technical mosaicism. ESHRE 2022, I think 50% of the conference was talking about this, and this is something that is very, very important on what is biological mosaicism versus technical mosaicism. I will not go into the details of what a mosaic is, because most of us know about it. And there have been a lot of papers about transferring of mosaic embryos. However, I want to just go to, there is the study in which 6 out of 7 live births are from mosaic, and out of 144 transfers, only 1 live birth from a real aneuploid embryo. This study was done in 2022. Now in this, the 2 miscarriages were not because of a mosaic, because an amniocentesis was done to confirm the karyotype after the mosaic embryo was transferred. Now, there was a paper by Diego Marin, pre-implantation genetic testing for aneuploidy. They did a reanalysis. And when they did a reanalysis, the original biopsy, there were 28 euploid and there were 289 mosaic. And when they retested it with a different embryologist, there was a 38%, and this was a very, very highly significant difference between the two. And that is where ideally, if you see all the data, the incidence of mosaicism in reality is as low as 1 to 2%. So if you are seeing too many mosaics in your practice, then there is something wrong with the technique of the biopsy, and that is where technical mosaicism comes. If you see the mosaic embryo, the misconceptions and misinterpretations in PGT testing for aneuploidy, if you see all of these studies, the total incidence was 0.04% of a mosaic embryo. And when they compared biopsy practitioners and mosaicism, and they see the variability in the mosaicism, it cannot be so much variable. So this is the study that was presented last year by Meena Popovich in ESHRE in 2022, where 10,875 PGTA cycles were analyzed from 18 different IVF centers and 8 different PGTA providers. And they found a difference which is so big, which is 2.9 to 39%, which is a very huge change. So here I feel that, and how do you confirm that it is not a actual embryo mosaicism, but it is only a technical error? If they compare the mosaicism over age, if you see, it remains pretty much the same. only the rate of aneuploidy increases. So there is a lot to do with technical. So if at all any of you are seeing a lot of mosaic embryos in your practice, then I think it is you should review the technique or the embryologist or who is doing it. And maybe if you have two different embryologists, compare the previous results and compare the mosaicism percentage between the two embryologists.
Erika, so and I'll just add something here. So, working in a center which had an in-house PGS, this whole concept of technical mosaic is definitely, very true, because, a lot of times it's not just we kind of always try to jump on the embryologist, but it's also not just the embryologist. Remember the lab that you're sending in, even like a droplet or an hair falling into anything is going to give you a different genetic report. So considering all these, as I think Dr. Ritu mentioned, the whole idea of the sequence of the embryo to transfer was to put into consideration all these factors. That is why when mosaicism was considered, now today there were a lot of criteria, but today we consider those three criteria. One, whether you have a low mosaic or a high mosaic. And when you say low mosaic means 20 to 40%. So you're giving that gap for a human error to still kind of play into picture and not kind of reject or discard an embryo. Then, of course, there is this whole, the second concept of, is it a segmental mosaicism or a complete chromosome that has been affected? Now, there you know that if it's a complete chromosome, and the third is the number, whether it's 1, 2, or a complex, which means there are multiple chromosomes that have been available. So then these three kind of give you a sequence of what Erika was talking about, to whether read the mosaicism with a pinch of salt, transfer them, and then ideally label them. Why do we label them low mosaics?
Yes, but when I read about this, I just felt that it will be nice for all of us to go to our previous data and have a percentage mosaicism for each of our own center rather than having a universal value. Moving on to the next case. 32-year-old female, married for 15 years, semen analysis had mild male factor, multiple cycles of IUI ovulation induction, hysteroscopy is normal. Antagonist cycle, 14 oocytes retrieved, endometrium on day of OPU was 7 millimeter, 4 blasts are frozen. After 18 days of estrogen, the endometrium was 5.5. Patient was counseled and cancelled the cycle in view of thin endometrium. So my question for Dr. Brajbala, how thin in your practice is thin endometrium and when do you cancel it?
Actually, it is not only the thickness of endometrium, although definitely this is the bottleneck of any success of the IVF. Because this is the rate limiting step. If we have good quality blast and everything is good, all hormones are good, then it is less than 7 millimeter is my cutoff. But not only this is tripling blood flow and volume, everything we have to take into consideration. So mostly it is minimum 7 millimeter. And if it is less than 7 millimeter, my number one intervention will be hysteroscopy first, if it is not done previously, even in spite of good quality 3D, 4D sonography. And the number of exposure of estrogen before transfer, there is no definite rule, but we can give up to, like in my one patient, I have tried up to 35 days of estrogen and I got positive pregnancy.
So, Dr. Nisha, if you see a thin endometrium, what is something that you do in the next cycle?
In this patient particularly, what I have seen is that HRT was used. So definitely we can use this FET stimulation protocol. So we can add on the modified protocol for this, because on the day of pickup, endometrium was 7 mm. So we can consider that changing the protocol and then jump to hysteroscopy, metroplasty, all other things.
So which protocol would you prefer to do?
So definitely stimulation cycle with the Letrose, and on the HCG trigger, and then follow the transfer after 7 plus 7.
So how thin is thin endometrium? Multiple, like Dr. Brajbala said, a lot of people do transfer in endometrium less than 6 millimeter also if it is triple line, if it is has a good flow, and pregnancies have been reported. And there's a paper of optimal endometrial thickness in fresh and frozen thaw IVF cycles analysis of 96,000 embryo transfers. And even they said that an endometrial thickness of less than 6 millimeter was clearly had a dramatic reduction in live birth rate. So any natural cycle propagators here?
Yeah, I would have done a natural cycle, a modified natural cycle for this patient rather than a letrozole cycle, because of the fact that I'm a little skeptical about the effect of oral ovulogens on the endometrium. So especially when the endometrium is as less as 4.5 or 5.5, then I would have preferred to do a modified natural cycle, which basically is tracking the follicle and triggering it with HCG eventually, rather than allowing it to rupture on its own.
I would also like to do a hysteroscopy. First of all, rule out other causes, why the endometrium is thin, whether she has endometritis, whether she has history of tuberculosis. Those are very important factors as to why the endometrium is not growing is also something. But again, the stimulation cycle you mentioned, that the only difference what you mentioned is that in the stimulation cycle, her endometrium was 7. So that is quite contradictory, frankly speaking. So yeah, maybe, but then still ruling out endometritis itself is very common in India. That is also something that we need to rule out.
Just a point for especially this patient. Sometimes you just need to give it a break. You don't need to do anything. Just give a 1 month break and try again. Just because your one cycle post pickup has not given you a good endometrium doesn't mean that immediately a next cycle you start doing all that is possible for thin endometrium. Of course, what to do for thin endometrium has been discussed by all the panelists, but sometimes you just need to give it a break. Just give it a break for 1 month, and then you will see the next month everything is fine, because sometimes too much of estrogen, too much of treatment that has been going makes your endometrium kind of refractory to these treatments. It's sometimes just good to give it a break for 1 month, and sometimes you will see that it just everything is fine.
Yes,
Can
probably
I just add on?
Sorry.
Yes.
Yeah, coming back to the point that Sheetal made, I think endometritis is something that we should always take into consideration in India. And even doing a good DICE test, like ruling out tuberculosis, doing DICE, doing Emma Alice, and ruling out chronic endometritis makes a lot of sense in these patients, especially with India being an endemic zone for tuberculosis.
Correct, Shrutika, but I don't know this, but as far as I feel, chronic endometritis does not really cause a problem of thin endometrium.
Yes, it does.
Oh, it does cause.
It does.
So in tuberculosis, it does cause.
It is more of
I know that there is going to be a sawtooth appearance, the junctional zone may not be. So those are additional factors, but thin endometrium is one of the commonest presenting.
All right, fair enough. In my observation, I was a little doubtful.
No, because we have done an egg retrieval, no? So a lot of times our needle may have gone through the uterus. So there are so many factors that could be causing this kind of a thin endometrium immediately after the stimulation. So especially in your case, Erika, when you mentioned that during stimulation, this was a thing, I would definitely want to rule out infections.
Your experience with natural cycle FETs, Dr. Nousheen?
So
and do you do them? And
so what I was trying to add earlier was that, after trying the maximum dose of HRT or the natural cycle, if the endometrium is not developing, I would like to add a tamoxifen, because it has an estrogenic effect. And we found that it gives even studies are proposing that it actually adds to the endometrial thickness. So if at all the natural cycle or the maximum dose of HRT, if it's not working, I would like to just add as an adjuvant. And coming to the second thing, hysteroscopy, I would prefer doing hysteroscopy only after, all the medical methods are not working. And if I feel that the pattern is not good, if I'm feeling some intrauterine adhesion seen, then or a chronic endometritis, as Shrutika ma'am was saying, then I would definitely do hysteroscopy. So coming to natural cycle, since this patient had a 7 millimeter, at least a 7 millimeter endometrium in stimulated cycle, I don't mind. If nothing is working, I'll try for a natural cycle.
Erika, coming back to RIF, especially with regards to thin endometrium. One of the interventions, there's a nice paper which has come out from Asha Rao about RIF, 2022, I think, where they have compared all, it's a meta-analysis which compares all interventions that can be done for RIF patients. And they have said that one of the things that they have proposed is intrauterine HCG infusion for RIF. When we are thinking about a uterine factor or an endometrial factor, not that it is going to increase the endometrial thickness, but it definitely improves the endometrial receptivity. That is one intervention that they have said that probably works. In fact, GCSF, PRP, stem cells, all those things have been compared in that meta-analysis. And currently, there is no conclusive evidence for any of the things that we have discussed so far.
Shrutika, do you remember the dosage that they have recommended?
For HCG?
Yeah, intrauterine HCG, because that is a lot of variation. I mean, what that paper would have mentioned.
Yeah,
if you
I use 5,000 IU, but there is nothing mentioned there. It is just saying intrauterine HCG, intrauterine infusion of HCG improves RIF.
I think it is 500 IU, Shrutika. It is not 5,000.
Because there are a
No,
lot
I
of
use a 5,000 IU vial is what I'm saying. I don't know how much.
No, but the dosage is only 500. It is just part
the problem with HCG is there is no consensus on the amount, and then there are a lot of people who feel too much of HCG is also a problem intrauterine. So
Right. I agree with what Yuvraj is saying. There's a lot of studies with different dose, different timing, different days. So I was also surprised to see that, as Shrutika ma'am was saying, that how come Asha Rao was when compared to all other adjuvants, this was given a moderate tick-on. But I still doubt.
Any of you are using GCSF?
I think all of us are.
All of us are using it. I'm using it.
What is your criteria and when do you use it? After how many failures? At what endometrial thickness?
So I use it 2 days before we actually start progesterones. Criteria is when the endometrium is thin, maybe somewhere around 6. That also they have mentioned that the endometrium has to cross around 6. And then you should preferably do the GCSF. So in those cases, I use the intrauterine GCSF. Again, there are options where you can give the GCSF intramuscularly also. That is something that I don't give because a lot of patients have a lot of bone pain also. So that is not something that I'm doing. But intrauterine I'm doing. Again, I don't know how well it helps, but it is working for my patients and I am giving it. Yes.
So if you're just starting 2 days prior to progesterone, how do you assess an improvement? Because 2 days later, you expect an improvement in 48 hours?
Yes, but that is the recommendation, Nousheen.
So are you finding an improvement in endometrial thickness in 48 hours?
It is so if
there are papers, they said about 72 hours.
Yes, 48 to 72 hours is the recommendation. So either 48 or 72 hours is the recommendation. And you can take the dose also on the day of progesterone, when you start the progesterone.
Okay, so I have actually tried both subcutaneous and intrauterine. I mean, quite some time back, maybe around some 5 years or something back. Didn't find, improvement. In fact, had to cancel many cycles.
So Nousheen, that is what I said. So whatever a lot of things that we are doing, the adjuvants.
Yeah, it's an
times we don't know. We are just trying to do whatever helps the patients is what I feel.
Right.
Frankly, in RIF patients, there's a lot of embryo glue. I don't know, maybe by the end of it, I will speak about it because I have also done a study about it. And I have seen at least 12% improvement in my pregnancy rate. So maybe by the end of the talk or by the end of the whatever panel, I'll speak about it. But again, it's an individual opinion or an individual experience that everyone has. So,
absolutely. I
the
agree.
GCSF was introduced in a few, probably 2010 here is the first study that was there, but multiple RCTs have been done after that and none of them have showed any difference in the pregnancy rates when it comes to GCSF. Coming to PRP, there are two things I wanted to ask as a question when it comes to PRP. Do you use hysteroscopically injected subendometrial PRP, or do you, if at all you are using, do you use just intrauterine infusion of PRP? Or
so in RIF cases, I would do intrauterine infusion. I think the only cases in which I would do subendometrial is for recurrent, Asherman syndrome, where I've done adhesiolysis, and that's why I have to do PRP.
The subendometrial, right?
Yeah, the
So
subendometrial.
Nisha, your opinion on PRP?
So definitely, I have tried both of these, intrauterine instillation as well as subendometrial, but unfortunately, I could not get any results. So whenever the patient is completely affording, if non-affording patient, I generally don't recommend PRP here because I have not seen personally any growth as such in the thin endometrium cases. Not even the endometrial volume also is increasing. So that's little no for me for PRP.
Yes, Dr. Nousheen.
Yeah, I had a paper published in Fertility Sterility on role of PRP. One group having subendometrial PRP, another group having intrauterine PRP, and the third was the control group for RIF. Actually, that study showed better results for PRP. But later, so I was so pro for it and I thought of doing an RCT. In fact, enrolled for an RCT. We did an interim analysis and we didn't find any difference. So at the moment, we are not doing PRP at all. So
multiple RCTs again prove
not
the same thing, that there is
not
no
intrauterine.
There is no difference in pregnancy rates in any way of doing PRP.
Anyway, so I'm not doing it at the moment, though the paper was published.
Coming to one of the most debated topic lately is ERA, and I want to ask: is
at
the
least
era,
this one we all will have a unanimous opinion? That
is the era of ERA is over? Dr. Sheetal, do you do ERA?
I am not so fond of ERA, so that is my opinion again.
Yeah, I never was, and I have not done so many errors. So I would not.
So I am not so fond of ERA.
And also, there is one article recently in 2022 SRM that is with the heading "End of Era." I think.
Yeah, right.
So I think the reason why we all believe that it is an end of era is because the same group that discovered ERA and published the first paper on ERA, the same group has now published and presented in ESHRE that and taken it back, saying that it does not give any difference in the pregnancy rates. And it is a very interesting, I'm going to skip it fast because it's a very interesting paper and a reflection that is there, like you said, in Fertility Sterility, that end of an endometrial receptivity era. It was published in 2022, a must read. And I think all of us have completely stopped doing ERA. Although I honestly, sometimes I do get very tempted when I don't see, when you transfer euploid embryo in a superb looking endometrium and you still don't get a pregnancy. But still scientifically, I think it's time to say goodbye to ERA. Like we already discussed about intrauterine HCG. So a recent Cochrane review identified 17 RCTs and the authors observed very high heterogeneity between the trials. And there were the thing with all these adjuvants is that there is not enough data to do anything about it. These RCTs for all GCSF, PRP, HCG, everything has been, there are too less number of studies, and here the dosage, like you were asking, is more than 500 IU increases the probability of clinical pregnancy rates and live birth rate. However, it is still not accepted as an add-on in many cases. Coming to the last case, not much time on this, 28-year-old married for 10 years. Mild adenomyosis, hysteroscopy is normal, 3 IVF cycles, 2 self and 1 donor failed outside. Consult for PGT in view of failures, underwent a self cycle, 16 oocytes, 5 blasts, transferred, euploid breast, negative. What can you offer the patient now? Put it back for you.
Like, if hysteroscopy is not done,
would not.
If
No, I
hysteroscopy
would not focus on the hysteroscopy or the adenomyosis at the present moment, because you mentioned that it is mild adenomyosis. And maybe in this patient.
Yeah. Sorry. Sorry, ma'am, continue.
In this patient, I think PGTA, establishing that there are euploid embryos, doing endometrial receptivity, studies using color Doppler. So all those things, not, I would not think about the uterine factor at the present moment.
What was the endometrium like?
What is the role of a repeat hysteroscopy in this patient? Do you do again, Dr. Yuvraj?
Yuvraj, you're muted, I guess.
I'm sorry. Not really. And especially if we've done the first hysteroscopy and then there is no other, factor in on the ultrasound, no. But coming to the case, can Erica, can we go back? So this is like an ideal case for recurrent implantation failure.
Yeah, for all the adjuvant.
Yes.
This is the space where the whole articles that you read needs to be followed. And here you can do all the sequence and you can follow everything that is possible. Starting from, of course, first is your lifestyle management, XYZ. Do a DFI, definitely. I would do a karyotyping in this case because we all know that, balanced, unbalanced translocation sometimes are missed on PGTA. You need a PGTA SR for that. So one is that. And second is, of course, types of, I would sometimes when, PGTA normal embryos don't stick, I try to go back and do a modified natural cycle. We were discussing a modified natural cycle. I would love to do a natural cycle, but I'm not at all confident. I don't know how many times wo LH kiya jata or 15 time raise and 30 time raise just confuses me. So I better do a complete modified natural cycle where I let when I say modified natural, meaning not letting anything, no ovulogens or gonadotropins, letting a follicle grow and just giving an HCG. So one is that. Second, of course, is, as we said, doing a complete workup in terms of a DFI, karyotype, and the other parameters of APLA, of course, again. And then, going it forward with an embryology part, as in what was the quality of the blastocyst, as Sheetal said, embryo glue, which has again come into picture after 5 years. So yeah, all that.
And Erica, your maybe immunological, sorry, Nousheen, go ahead.
Yeah, so, because the case is about, I agree with whatever the Yuvraj was saying. Apart from that, I would like to actually, as Asha ma'am was saying, treat the adenomyosis by giving an agonist. Also, very often I find a hydrosalpingo is associated with an adenomyosis and endometriosis because these are mostly coexistent. So ruling out an HSX is a must in this case, I would say, like apart from the parental KT and other evaluation.
And Erica, also,
what do you use, Dr. Shrutika, for treating adenomyosis in your practice?
Here, no, honestly speaking, I would have only given GnRH agonist if I was strongly suspecting adenomyosis. But like I said, in your case, which is so picture perfect, there are 16 oocytes, 5 blastocysts, you've established, done PGTA, they are euploid, everything seems picture perfect. So this is probably the case where I start investigating from immunological point of view. Like Yuvraj said, maybe go back to the history, see if there is any hypothyroidism, do the anti-thyroid antibodies, try to find out what is the TNF alpha, is it high on the higher side, is there any other immunological, because you also mentioned that there are 2 self IVF and 1 donor IVF. So that means in spite of taking donor oocytes also there has been a failure. So then here all those other antibodies, whether the anti-sperm antibodies are positive, all those, that thought process more kind of clicks in more than thinking about adenomyosis. And if at all, then I'm convinced that it is nothing other than adenomyosis. Then because also endometriosis goes hand in hand a lot of times, then I would like to do a laparoscopy, make sure that there are no peritoneal endometriotic spots that require fulguration, because sometimes that is supposed to improve the milieu, and then only think about giving GnRH agonist.
So coming to treating adenomyosis, since Asha ma'am spoke about it, I really want to know from a clinical or a practice point of view, Dr. Brajbala, do you use aromatase inhibitors for adenomyosis?
Not too much, just in one patient I use, but I not got any results, and I'm not having much experience using aromatase. That is a mild case of adenomyosis if I'm having it.
Dr. Nisha?
I have personally not used aromatase inhibitors, but GnRH analogs, definitely yes. And in this case, I would say that the patient was her two pickups were her pickup was done, two ETs were done, one donor cycle, but male parameters are under investigated. Only it is said that HSA normal. So we should be investigating on more on sperm parameters, and why not change the sperms then if the gamete change has to be done. So for young patient AMH 3.6, 16 oocytes. So at least change the sperm.
Anyone else using aromatase inhibitors?
I have tried for 1 or 2 patients, but I don't have a control group for a comparison to actually say. So it worked for that patient. I gave 11.25. With that, I had given 2.5 milligram for 2 months. The uterine width actually came down, but I don't know whether, agonist alone would have worked or not. I was just trying it out. So I don't have a comparison as such to say.
I think for reduction of uterine volume, that too in severe adenomyosis cases like uterine sizes where they are 14 weeks, 16 weeks uterus, then it is only a comparison between GnRH agonist and Mirena insertion. In fact, I have tried Mirena insertion for a patient and that has brought down the uterine volume better than anything else. So I think LNG-IUS is a good option.
Anyone else has a difference of opinion? So won't spend much time because Asha ma'am already covered this. And yes, I think, so what I personally do is use only agonist in case of a mild adenomyosis and add on to pituitary suppression with GnRH agonist, which is a little insufficient when it is a case of very severe adenomyosis. And that is where we use aromatase inhibitors, and it has worked wonders in bringing down the size and severity of the adenomyosis.
Erica, I would like to add on. See, one of the another reason why they're suggesting to give aromatase inhibitor is apart from the reduction of the hypoestrogenic one, they say that it's basically the endometriosis is a condition of progesterone resistance. And this actually reduces the aromatase activity. Also, letrozole has got an action on improving the implantation by improving the integrin levels and all. Alteration of HOXA and integrin levels. So they said that letrozole works on different level. I mean, 2, 3, but all those are theoretical ones. There's no proven as such an evidence strongly suggesting for any, but it's not just the uterine volume that they're focusing on.
Yes, but it does reduce. The only issue with letrozole is if you really want aromatase inhibitors to work, you have to give it for a minimum of 30 days and sometimes a maximum of 60 days. And that when you're doing that, you have to supply calcium and indeed, because that is something that we have to be very careful about osteoporosis.
What dose do you use, Erica?
2.5 milligrams per day for 30 days.
Okay. Why don't you tell us the protocol that you use to handle patients with adenomyosis, where you use letrozole and hysteroscopic flushing? Because I think that will help all of us to kind of take a good
hysteroscopic flushing as well.
So yes, so what we do is we do like a 3-month protocol in case of severe adenomyosis, where the first month is agonist. The second month we give a 30-day letrozole and a second dose of agonist after 1 month of the first. Third dose of agonist in the 3rd month, and after 2 weeks of agonist we do
3.75 you give every month.
Yes, for 3 doses. Yes, and 1 month in between letrozole. And then we do something called as hystro wash, where we just take the hysteroscope to the internal os and just rinse out the cavity, and immediately the next day we start HRT.
So what's the idea behind that?
A little bit of aseptic inflammation just by jets of water. We don't touch the endometrium, don't enter the endometrium. And the day after we start the HRT and transfer.
It's agonist plus letrozole the second month, then agonist again, and then you do the uterine wash.
So when you do the uterine wash, you are essentially not allowing the patient to bleed in between, and you just want to remove out the...
After the 3rd dose of agonist, a patient won't bleed.
There's no bleed, right? So what is the idea of doing the flushing, the uterine wash?
just trying to create a little bit of aseptic inflammation, it causes better regeneration or better growth of endometrium.
Something like a scratch, endometrial
So
scratch.
if you do this, yes, something like that without without injuring it too much. So when you do this, we do about say 10 or 20 flushes, you will see like tiny spots of blood that starts coming out. It starts bleeding.
So did you have any control group to compare, and what was, I mean, what actually, you know, why do you think that the endometrium will not develop? I mean, what was the reason why this was, you know, found, like, actually
No,
introduced?
we are still like in process of doing this. We've done very few cases for me to even comment, but
right.
So this is Dr.
But it's
Fatemi.
interesting to know about, I mean, you know, different protocols.
So this is Dr. Fatemi's protocol, which now they are following at ART India, but they've already done their, you know,
Quite a few
study there at Abu Dhabi, and they are in the process of publishing it. So these people are now following it, and me and Erica were discussing about it, and that's what I thought that, you know, it would be a good take home for us to also maybe, you know, if nothing's working, maybe we can try this, because Dr. Fatemi is someone who is kind of, you know, endorsing it. So I think it's something that we could
probably we still have to do the statistics and see before saying anything conclusive, but looks like it is something is working. But like ma'am said, when it comes to adenomyosis, I think how to do and how much of a suppression to do is something that we have to take patient per patient individualization. So thank you so much. Thank you so much, Komal ma'am, for giving me this opportunity, and Dr. Ritu for giving. Thank you so much, my favorite panelists. These are anyways.
Thank you so much, Erica. Thank you, Komal ma'am.
Thank you so much.
Thank you.
Thank you.
I could see the discussion going so well, you know, with a lot of conclusions and the way each one of you have given your points, you know, really strong take home messages and lovely discussion. Very great moderation, Erica. I think I was more interested here. I'm an expert in some panel somewhere, but I was more interested here, you know, to listen. My one ear is always, this was more interesting kind of. So I think you all kept
passionate about what they're doing in this panel, you know.
Yes. So it was really very
IVF specialists are right here.
Yes. So everything is all nice. Everybody has done such a wonderful job. Thank you each one of you for being Sheetal, Nousheen, Brajbala, Nisha, Yuvraj, Shrutika, and Ritu, above all, flawless, superb coordination. Thank you so much, and Kalyani. And Erica, you are a star today.
Thank you. Thank you. Thank you.
Thank you.
Thank you, everyone.
Thank you. Bye. Let's meet and stay tuned for the next webinar. Bye. Thank you, Shield Connect team. Thank you so much.